Please rise.
The face. Post the collar. Present arms. Please join us in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Forward arms. Left face. Forward up. Detail. Halt. Dismiss.
Good afternoon, everyone.
Good afternoon.
I'd like to welcome everyone that's here in person and also all those people who are attending online, virtually, to the 7th Annual Healthcare Innovation Conference, and in this year, virtual live stream, which is something new for all of us. And of course, we've all gotten used to doing things virtually. Now, if I can figure out the clicker. That's not what I wanted to do. All right, a couple of housekeeping things. Every speaker that you're going to see and their presentations are in the booklets for those that are here in attendance. And for those of you attending virtually, those were emailed out to you, so you should have all those things available. For the people who are here, if you do have any food allergies and you're planning on attending the reception afterwards, please let us know so that we can make sure that you don't eat something that you're not supposed to. Also, not only for the people here in person, but for the people who are attending virtually, we will have surveys that we will be sending out so that we can get feedback on what that you liked, what we didn't do so well, just so we can improve the annual conference every year. And again, a couple more housekeeping things. If you're getting up to go to the restroom, we do, or to get drinks, and there are drinks in the back left-hand side of the room, to my left, of water, soft drinks, and coffee. If you do leave your table, we do ask that you put your mask on. Restrooms are in the back, to the left of the stairs, all the way to the back there. All right. And as a reminder, one little commercial here. We are having an October webinar series. Our first one will begin October 6th, and it's a round table where we're going to be talking about pressing issues within a pandemic. And one thing for the speakers, every time we have a new speaker come up, we're going to have someone sanitize the clicker and also change the mic covering for COVID-19 purposes. And nothing's happening. All right, as I mentioned, there is a cocktail reception afterwards, and that is at the rooftop of this hotel, so you just take the elevator up to the roof. It is open air, so luckily we've been blessed with very nice weather today, so and a little bit of a breeze. So I think all the COVID-19 experts would say that's probably the best case scenario you can get: open air and a little bit of a breeze. Although you're certainly encouraged to wear a mask as well. And there'll be drinks and some light appetizers. And here we go. Obviously, anytime you put on any kind of event, you have to have sponsors, and we certainly want to thank our sponsors, MedBen, also known as Medical Benefits. They're a third-party administrator. They do a great job. We've been working with them for years. American Fidelity, which they have voluntary benefits, and also this year, what's becoming more and more important are enrollment options in a COVID environment. How do you go through open enrollment? They've been a great help in that. Health Status is a organization that has another way of looking at clinics, and we'll hear a little bit about that later. HM Insurance Group, that they're a stop-loss carrier that we've had a great relationship with for years. And Payroll Partners, they're a payroll company, imagine that. And they're who Sherrill Morgan uses for their payroll. So that should tell you a little bit about what we think about Payroll Partners. So thank you, every one of those sponsors. And the staff, nothing like this can be pulled off without the help of or not the help, but the actual work of the staff. And when I say the staff, I mean Sherrill Morgan employees. And specifically this year, we've had a big challenge because, as you can imagine, what was allowed, what wasn't allowed, changed almost daily. So venues changed, what we needed to do changed. And to make it even more challenging this year, traditionally the two main people that work on this are Sarah Brophy and Amanda Marchione. And Sarah was out on maternity leave for the vast majority of this. So a lot of this fell on the very capable shoulders of Amanda Marchione. She did a tremendous job. I think we should give her a round of applause for that. Hopefully she heard that. She's back there. And there are other staff members who are here, Joe Jones, Stephanie, a whole bunch of people that I'm going to forget names, so please don't get mad at me if I've forgotten your name. But you know who you are. But everybody pitched in and did their part. Where am I pointing this at? All right, so what we're going to do is we're going to have speakers come in and talk about various topics. One of the things that changed as we were putting this on, and of course we started working on this months before the pandemic even began. So, but once the pandemic hit, then some of the topics needed to be changed as well. So we're going to have speakers that address those types of issues, and I think it'll be very valuable. And this year we have to condense it into essentially an afternoon, where traditionally we've done a day and a half. But I still think it's an information-packed event. And I'm done with my speaking. I'm going to turn it over to our founder, Sherrill Morgan, who's going to give you a little bit of a history. There is a setup in the back. Sherrill Morgan himself, when he was starting in the insurance business, this was the building that his office was in, and it was on the second floor where we're at. So he can probably tell you a little bit more about that. I wasn't around back then, or I was like 3 years old or something like that. So, Sherrill, I'll turn it over to you.
All right, thank you, Mike. Mike's been a wonderful, wonderful partner for the past 25 years, I guess, or 30 years, Mike. I don't know how long. He's done a great job, and okay, well, last.
Because the broadcast shuts off tonight.
Okay. Yeah, it was right back in the corner. Okay, Joe? All right, well, I want to say thank you for being here virtually or being physically here with us. Yes, my office was right back in the corner there. I know that on the other side of my wall was the toilet because I could hear them guys go in there, ring. I could identify them by how they rang the toilet. But anyway, born across the river, Newport, Kentucky, right across the river, the intercoastal, I call it. But the high school, most of the guys went to high school went to the brewery, Wiedemann Brewery to work, or went to the Newport Rolling Mill, or to one of the casinos. And I went to the railroad for a year. Always wanted to play football, kept getting cut from all the larger colleges. And So Wilmington College up in Ohio came by and said, hey, if you come to school here, we'll let you play football. You can work 3 days a week, go to school 3 days a week, year-round, 4 years, you're out of here, you owe no money. It's a good deal for me. Out of college, into the Army, 2 years. Out of the Army, coached football a couple of years. Actually got to be head coach 3 years and won a game every year. And they fired me. I couldn't believe that. The guy who followed me won 0 games. But then my wife and I decided that I should seek a different career. I always worked 2 jobs, had door-to-door sales, Fuller Brush, sterling silver, fine china, various jobs, and interviewed with Procter & Gamble. They wanted to send me someplace in the USA. My wife said, no, I'm not doing that. And Ross Pharmaceutical wanted door-to-door salesman to call on doctors, and she said, no, you're too impatient to do that. So my Rhonda, my sister, worked here. So she told my wife I should come over. They hired me, and it gives me a really kind of a tingling sensation to know still here, 51 years later, and still doing, you know, what I do what I do because I enjoy it. I talk to a lot of football players and baseball players, and you ask them, would you rather be doing something else? And they say, no, I'd like to play baseball. They call them players. They call them football players. They call them tennis players. They call them baseball players. Well, I don't consider myself an insurance salesman or an insurance producer. I really think of myself more as a player, an insurance player, because I love what I do. And I made promises to people who became my customers 50 years ago, 30 years ago, that I want to keep. I want to keep those promises for as long as I'm healthy enough to do so. Wonderful, wonderful experience working with Mark, Valerie, Mark, Andrea. All 3 of my children are just incredible kids. They've all 3 worked with me. They only work with me as long as they can endure me, because I'm a pretty hard-nosed, disciplined guy. And but Valerie does a terrific job in marketing our group insurance, our self-funded group insurance. My daughter Andrea worked there for 7 years. Andrea is more subtle. But she's very quick to capture your heart. I go on appointments now, and I can have people who look at me, and they or look past me over my shoulder. I know what they're looking for. They're looking for Valerie or looking for Andrea to be with me. But you know, I'm very blessed to have them as my children and have them as my partners. Well, thank you very much again for being here. I enjoy it. This is my old location, and I feel good about it. Thank you. Bob Abrams, by the way, will be introducing our speaker.
Good afternoon. My name is Bob Abrams. I'm with the Green Township Veterans of Foreign War, and I'm here today with Ed Burke, who, by the way, just celebrated his 100th birthday, so we're very excited about that. Also, I have with us our color guard, Mike Donnelly, Jim Crane, and Tom Schmidt. And one of my most favorite things to do is to introduce this gentleman. He's truly a World War II hero. And just to set up the presentation a little bit, I just want to give you a little introduction of what Ed has accomplished during the war. Ed Burke was a company commander with the 821st Destroyer Unit attached to the 29th Infantry Division. He was awarded more than 10 combat medals, citations, and award, including the Silver Star, which is our second highest medal that can be given, and it's one of the highest combat decorations. He also received the Bronze Star, 5 Bronze Campaign Stars for battles in D-Day, Normandy, the Rhineland, and Central Europe. From France, he received the French Croix de Guerre, which is the Cross of War, French Legion of Honor, which is one of the highest decorations that a combat soldier can receive that is not a member of the French Army. Additionally, Ed landed at D-Day Normandy and fought his way through Europe and eventually the Battle of the Bulge. One of the other things that he did in his accomplishments was help liberate the Nordenhausen concentration camp. And after that, he was blessed and honored to present the flag of the 29th Infantry Division at a ceremony opening the Holocaust Museum in Washington, D.C. When Ed got done with all of that, he met the Russians at Torgau, West Berlin in 1945. What I want to do to just set up the presentation a little bit, I want to read the Silver Star citation that he received. Captain Edward A. Burke, 821st Tank Destroyer Battalion, U.S. Army, for gallantry in action against the enemy in Germany. On February 23rd, Captain Burke, exposed to intense enemy fire and disregard for his own safety, crossed the Roar River and reconnoitered for gun positions for his platoon to occupy immediately after they crossed the river. Again, on February 27th, during the attack of Holzweiler, Captain Burke, exposed to enemy fire, advanced across open terrain, reconnoitering under direct observation of the enemy. He called in smoke to be laid down on the enemy, allowing the infantry and tank detachments to move across in safety and secure the objective. That's a picture of his Silver Star, and this is when he was awarded the Silver Star in Europe. Ed has been involved with so many things during World War II and so many battles that we don't have enough time to cover all of that. But what we are going to cover today is one of his stories. And today Ed Burke's going to talk about the Battle of the Roar River, where he won the Silver Star. What makes this even more interesting, his exploits, unknown to him during the battle, were actually documented by Life magazine and published in March 12, 1945. What's further interesting about this, Ed didn't know about this Life magazine article till about 2 years ago, and he's going to give you a little background on what happened there. So ladies and gentlemen, it's my distinct honor to present Major Edward A. Burke.
Can you hear me all right? Well, as Bob Abrams said, I was a member of the 29th Infantry Division. Now, as you all know, the 29th Infantry Division is the one that made the D-Day landing. So all the pictures that you see of Hollywood and everything like that about Omaha Beach, that was the 29th Infantry that landed at Omaha. It was personally selected by General Eisenhower because the boys in those divisions, there were 3 regiments, the 115th and the 116th and the 175th. Those boys' ancestors were in every war that the United States ever had. In the Revolutionary, before the Revolutionary War, General George Washington, at that time he was the colonel, was the first regimental commander. In the Revolutionary War, Patrick Henry was a regimental commander before he became governor of Virginia. And in the Civil War, Stonewall Jackson was the regimental commander. Now, as Bob mentioned, these pictures that you're going to see, I never knew existed. But a number of years ago, there was an article in the Western Hills Press that a fellow named, there was a fellow from the 29th Infantry Division, and that he had been involved in the battle of the Bulge and the Roar River. And I called up the widow, and she said, "You want to talk to my son, Tom Neuheisel? He's got a lot of information, and I'm so glad that you called us." So Tom came over to my home, and he brought with him a booklet. And in that booklet, this was in Life magazine. I never even knew this existed. The fellow that was there taking the pictures, I thought he was a regimental or a engineer from the 29th Infantry Division. So all of these pictures that you're going to see was in the Life magazine, and I didn't even know these things existed. But what had happened was this. The 29th was personally selected by Eisenhower, and this was to be the crossing the Roar River. Now, the Roar River was about maybe 30 miles west of the Rhine River, and what he wanted to do was to get all the regiments in the Corps lined up in a straight line that the Germans' tank divisions couldn't get in back of us. Now, my job at that time, I was a company commander of the tank destroyer outfit. I had started out with the field artillery. I thought that I wanted going to be in the field artillery where the Marines and the engineers and the infantry all would be ahead of me. But every camp that I went to, they also had a armor division, and I ended up in the armor division. So my well-laid plans didn't work out so very well. So all these are pictures crossing the Roar River. Now at this time, in the Battle of the Bulge, this was the worst winter that they had seen for many years in Europe. So my job was to cross over the Roar River by myself, unaided, and check out the lay of the land and whether my tanks or my tank destroyers, once they got across the Roar River, would we be able to handle the German tanks, which we know would be arriving soon now. Now, I had flown up and down the west bank of the Roar River, so I knew exactly where I wanted to go. I had good maps of the area, but just looking at a map wouldn't tell you what the quality of the roadway was, or whether the moons, or whether we would get stuck. So that's what are all these pictures here. But what I had to do, I had to go across the river, and I was scared to death and afraid that I would step on a mine. So what they did, the Roar River at this time was in flood stage, and it was about the size of the big Miami River up there in Anderson Township in flood stage. So at that time, I would say about 100 or 125 feet. So my job was to go in advance, and then none of this had been erected at that time. I was there about 2 o'clock in the morning by myself. They had rowed me, 2 engineers had rowed me across in a little rowboat, And what they were going to do is try and get this footbridge corrected so that they could get enough men over there to erect a pontoon bridge. So that is what happened on this thing here. So when Bob, or rather when Tom Neuheisel came over, he had given me this booklet, which I had taken with me. And then I went down to the Ohio bookstore, and fortunately I was able to get a copy of the Life magazine that was in that particular area. So everything worked out all right. As I said before, now this is a number of my of the crews. In a company there were 12 tank destroyers, and in the battalion we had 36. Now that's me in the front there with the eyeglass on, and now the tank destroyer, the M10, that was more powerful than the Sherman tank. The Sherman tanks that you all know about had a 75. We had a 76 and 90 millimeter gun. Now all these men were on each head, and he was the commander of an individual tank. Now in the tank destroyers, they had no closed turrets, so I could stand up and see 360 degrees to find out. The only advantage that we had over the Panthers and the Tigers, we were faster. The reason we're faster, we didn't have enough protection as far as the outside of the tank. We had about maybe an inch and a half of armor. They had about 3 inches, 4 inches, and the King Tiger weighed about 52 tons. We weighed about 50, or we had about 30 tons. So anyway, I went across, and fortunately I didn't encounter any mines or anything like that. And then I came back, and then by that time they had all the other second armored and the rest of them lined up in back of me, but I was the first one over. And I had a map, and I know exactly where the tanks were in the Ardennes forest. So we were able to take care of them, and then by that time the P-38s and the 47s came over, and they took care of the tanks that we didn't take care of. So from there we went and carried, the next day we were at Burke, and then we conquered Mönchengladbach, which is the biggest army, the biggest German city that had been conquered. So then after that, of course, we crossed the Rhine River, went to the Elbe River, and we liberated Nordhausen prison camp. Now this was the second worst camp in that the Germans had. And then at that time, the Russians would not agree to the proper division of Berlin, so I had to stay along until our outfit had to stay along until our outfit had completed the taking care of all the problems that we had.
Ed?
If there's any questions, I can answer for a few questions.
Hey, Ed, before you get to questions, I threw a couple bonus slides in you might be interested in, and I thought maybe you could comment and see if anybody recognizes any of these people in the slides. This was when Ed was invited back to Normandy last year for the 75th anniversary, and somehow Ed wound up with Melania, Donald, the president of France, and a few other people there, and it's shaking hands with our president. And I thought that might just be something you'd be interested in, because what happened, I knew Ed was over there, and I turned on the TV at 6 in the morning, and as soon as it came on, I saw Ed. And I said, Ed, what are you doing? He says, oh, I'm with the president and all the well-to-do people here. So that was pretty exciting. But I thought maybe we do have just a couple minutes for questions. If anybody would like to ask Ed a question or two, we've got
Well, one other thing I'd like to mention. My grandson is Jimmy Herman, professional golfer, and Donald Trump is his sponsor before he went into the White House. So I have a lot of pictures now, and those pictures on the 75th anniversary of D-Day, I was in the front row, and Donald and his brother, and now next to him is Emmanuel, the president of France. So Donald, I mentioned to him, my grandson is Jimmy Herman. He said, oh, he's a great golfer. So what happened, Donald, all this is on TV. He's got a number of golf courses, and Jim was the low man in Ohio when his high school won the state championship. And he went down to Florida, and he got involved with the golf courses down there. And Donald was very helpful to him and became his sponsor. And right now, whenever Donald has a chance to take a holiday or something like that, he gets two of his friends and they play best ball against Jimmy Herman. Now all this is on TV, and then after it's over, Donald will say, yes, it was very close. Jim barely beat us out. Well, Jim probably beat him about books. 10 strokes or something like that. But he's been very helpful. But I didn't sit next to him. He sat next to me. And he brought me over. So he introduced me to all the big wigs, the Prince Charles and the lady that's the head of the Germany. And of course, Emmanuel and his wife, Bridget. Could you hear me all right? Did I miss anybody? If I had had an M10, I wouldn't miss anybody.
How old were you when you were drafted?
Well, what I had done when I was a junior in high school, I went to St. X downtown here, and I thought, boy, oh boy, I'm going to get involved with the draft. So what I'm going to do, I'm going to get in the field artillery where the engineers and the infantry and all these other branches are going to be ahead of me, and I'll be safe back in the artillery. Well, every camp that I went to, they also had an armored unit, and at that time, this was 1938, we had one armored division, Old Ironsides, and at that time, General Patton was gung-ho about the Armored Corps. And when I was there down at Fort Knox in the summer of '41, when we had our summer vacation down, I can hardly say a vacation, but when we were down for the month of '41, General Patton was gung-ho, and he was trying to form the 2nd Armored Division, and he said, whoever sees this outfit in Convac is going to see a hell on wheels, and that's how the 2nd Armored got the name, Hell on Wheels.
Yeah, Ed was, actually went through ROTC at XU, Xavier University, and then 2 years ago was inducted to the Hall of Fame over there. But this is just one slice of his resume that we're talking about today. But I know you have some time constraints here, and I think what we're going to do is, Mike, you want to come up, Mike Donnelly? What we're going to do is retrieve the colors. And we're going to take those back with us because the hotel didn't have a flag. So in case you're wondering what happened to the flag, we're taking it back with us. But we'll retrieve the colors, and we'll hopefully keep you on schedule here, Earl.
Mike is our commander of the Veterans of Foreign Wars out there in the Western Hills.
detail. Hope. Left face. Reset. Arms.
Retrieve the collars.
Or arms. Left face. Forward. Up.
As you know, it's always a tradition within our organization that we honor our country and we honor those that have served our country. And as long as we're able to be honored by the presence of World War II veterans, we'll continue to have them be a part of our organization's annual meeting for the future to come. Having said that, I'm very honored to introduce to you a partner with our organization for many decades that have served our customers well and serves them still well today and hopefully in the future as well, and that's a company called MedBen. Caroline Fraker is a significant part of that organization. Today she's going to speak to us about a very big growing concern within the healthcare industry, and that's specialty drugs. Caroline, thank you.
Good afternoon, everyone. I just want to thank the Color Guard. That was an amazing story. Wow, I can't really follow that story. I have no fun tales to tell. But I can talk about specialty drugs and pharmacy a little bit in general. I want to do that today. So we're going to spend some time talking about, first, the barriers to controlling drug spend. Those are increasing and have since the Affordable Care Act. I was going to say a dirty word, but I won't in mixed company. This is the way I feel about the whole thing. We're going to spend some time talking about that. We're going to talk a little bit about the increase of drug prices and as well a sort of change in the flexibility of PBMs. And then we're going to actually talk about some solutions. So I'm not going to just leave you with all bad news and having nothing good to report. But I want to start with the Affordable Care Act. One of the things that I think has happened with the Affordable Care Act is we spent a bunch of time when it first passed talking about the basic regulations and how that applied to co-pays and plan design and eligibility and how we were going to avoid the employer shared responsibility penalties and so forth. And prescription drugs sort of came in with regards to the Affordable Care Act and a concern because they were considered an essential health benefit. But really the Affordable Care Act nor the implementing regulations gave us any real direction on how to start thinking about prescriptions in general. Yes, they're an essential health benefit. That's pretty much all they said. They've given us some restrictive direction, but no guidance with regards to how we're supposed to continue to think about prescription drugs. If you are self-funded, you are allowed to not cover any of the essential health benefits. As you remember, there are 10 essential health benefits. So technically, from an Affordable Care Act perspective, you can not cover prescription drugs. You can exclude them altogether from your plan. That's sort of an interesting thing because what's happened now with the discussion on specialty health and specialty drugs is that people want to exclude specialty drugs from their plans, but cover other drugs under their plans. And that's really sort of a hard thing to think about when you look at the rules. My job, I'm Senior VP at MedBen, but I started and continue to be the compliance officer. I live and breathe on regulations. I like reading regulations, right? So I'm one of those weird people. We have to have them, right? It's like accountants. I look at them and go, how do you add numbers up all day? Ew. I read regulations all day. Great. But when I read them over and over again, I can't find a way to propose or support carving out specialty drugs altogether and keeping other drugs in place. You know, again, the implementing regulations keep offering us additional ways to sort of manage prescription drugs, but not save money on prescription drugs. If you are trying to offer your employees minimum essential, or offer your plan as a minimum essential coverage and not pay a penalty, there's certain things you have to do. You can always offer a plan that doesn't meet minimum essential coverage, and if you have more than 50 employees, pay the penalty. That's perfectly fine. But if you're trying to offer the plan and still not pay the penalty, if you're a large employer and you have a huge plan spend, you don't want to also pay a penalty on top of that. To do that, one of the things that came out sort of over several years, from 2014 through 2018, was this idea of what minimum essential coverage really was. Originally, it was just employer coverage. If you offered coverage, it was minimum essential coverage. And then we had the onslaught of skinny plans, right? And there were all these people offering skinny plans, and the tri-agencies, in this case, Treasury or IRS, HHS, and DOL, came out and said, well, if it's going to be a minimum essential coverage, what it really needs to include is all inpatient services, all outpatient services, and the United States Preventive Services Task Force preventive drugs. So as long as you're covering all that, you've got minimum essential coverage, and you can go on from there. But they also didn't provide us any direction on what inpatient services mean or outpatient services. I would argue that without that specific direction, that means that that's drugs. Inpatient services that are billed on a UB or a HCFA, you're going to bill drugs on that. It's going to be really difficult to carve out any of the drugs on an inpatient bill, because we have to cover inpatient services to meet minimum essential coverage. So again, very restrictive with regards to that. They did give us some guidance with regards to what the prescription plan might look like. You have to cover at least one drug in every therapeutic category or class. The US Pharmacopoeia is what gives us those categories and classes. Those aren't specific medical conditions, they're groups of medical conditions, right? So if you can cover one drug in each of those categories and classes, if you can model your formulary that specifically, or you can match a benchmark plan. If you're fully insured, you have to match the benchmark plan in the state in which that insurance policy was actually approved. If you can do those things, then again, you can work with that formulary and perhaps manage the drug spend a little bit that way. But how do you do that? How do you know if you have one drug in every therapeutic class? There's been a lot of talk about offering generic-only plans, which is perfectly fine. Again, we have this regulatory guidance that gives us sort of this guidepost to what we can do, but it's not very clear, except for generic plans. There was specific regulatory guidance that came out and said, yeah, you have to do all these things. You have to cover inpatient services. You have to cover outpatient services. That would include drugs. But you could also just have a generic plan. These days, with high-cost generics in the pipeline as well, generic-only plans don't necessarily mean lower cost, but you can do that. If you have a generic-only plan, again, you still have to cover the US PSTF, the United States Preventive Services Task Force drugs, the preventive service drugs, which now include, starting in the first plan year after July 1, you have to cover HIV drugs, which can be costly. So again, we're not necessarily talking about these preventive drugs being inexpensive or low-cost generics. So we want to make sure that we've found a way to manage that. I realize I have failed to move through my slides. I get talking. This is what a regulatory brain does. So we talked about those classes. But again, the way the Affordable Care Act has left us is technically a barrier to controlling drug spend. Another barrier that's been in place for a long time, and we tend to sort of forget about it when we're talking about drug plans and implementing changes to our formularies, are the HIPAA non-discrimination rules. You know, HIPAA brought us all kinds of things, including privacy and security and administrative simplification, but it also had this component part about non-discrimination. And the non-discrimination rules basically say that you can't discriminate in a health plan either on eligibility or the benefits offered based on a health status factor or a health condition. One of the things that's happening now more and more, particularly with proponents of specialty carve-outs, which, you know, I'm sort of on the fence about from a regulatory perspective, but if you're talking about doing that, or if you're talking about offering a generic-only plan, I'm gonna have a generic-only prescription plan, but I'm gonna carve a few drugs in, I wanna make sure I'm covering my diabetics. I wanna make sure I'm covering my my employees that have airway restrictive diseases. We really have to carefully look at HIPAA and those non-discrimination rules. If we're talking about generic only and I carve in diabetes drugs, I probably don't have a problem. Diabetes drugs are primarily for people with diabetes. They don't have crossover, they're not used for other things. When we talk about some of the airway obstruction drugs, they can be used for airway conditions, for COPD, but they can also be used for other things. So if my generic-only plan carves back in some airway drugs, I want to look at what those are specifically. I want to know, am I putting a drug back in that per my plan language and my intent, is only to cover it for one medical condition and not for something else. If it gets prescribed for that other drug, is that member going to say, you're discriminating against my particular health status condition, my particular issue? And that's a problem. It can also be a problem with orphan drugs. Orphan drugs are those generally extraordinarily very expensive drugs that we want to carve out of our plans, right? We want to make sure we're not covering if we don't have to, but they're one drug for one specific medical condition. How are we going to handle the HIPAA issue when that person comes onto our plan? Do we have a person on our plan? What happens if we get a person on our plan and we aren't covering that particular drug? How do we handle the HIPAA issues? These are some of the things from a regulatory perspective that sort of stand in our way from controlling cost. The other thing that stands in our way particularly is just the cost itself. GoodRx just came out with this survey in September of 2020, just last month, and it was comparing the cost of other medical services and supplies to the cost of prescription drugs. And prescription drugs since 2014 have increased 33%, which is a greater amount than other medical services and supplies. Not surprising that 2014, you know, why did we use 2014? Even though the Affordable Care Act passed in 2010, right? 2014 is where some of those really restrictive, out-of-pocket maximum limitations came into place, when all of a sudden we had to cover prescriptions and medical services over those out-of-pocket maxes without any caps, without any limitation. So all of a sudden we see the increase of drugs sort of correlating with the inability or sort of non-compliant offering to not control them in ways we had before, whereas we may have said, we're only going to cover $50,000 of any drug. That's it, across the board, no discrimination, whatever it is, we're only going to do that. Now we couldn't do it, so you know, how do we handle that? Also, in the last 10 years, we've seen a huge increase in medical technology, innovation, evidence-based research, which is a wonderful thing, but all of that costs money, right, which translates to higher drug costs. We've also seen increases in consumerism and marketing with regards to that. You can't turn on the television. I know everybody says this in every prescription drug talk, right? Can't turn on the TV without seeing ads for drugs, very specific, pointed now drugs, and where you go to your doctor and say, I have this condition, you know, I would like to have the latest and greatest drug, can you prescribe that? And the doctors are also targeted, right? And so we have all of these things which we have to contend with as we move towards trying to find solutions on our prescription plan. The other thing that's kind of changed a little bit are the way that pharmacy benefit managers, or PBMs, are dealing with those things as well, right? PBMs have to deal with the high cost of drugs as well. I think of the changes to PBMs a lot like I think the changes to PPOs. When PPOs started, there was a pretty direct correlation between the number of patients I was going to see as a doctor and discounts I was going to give you if you moved your patients my direction. So my business grew, I gave you some discounts, pretty straightforward. Same with PBMs. We'll manage this formulary, we'll help you figure out what drugs, we'll get you some discounts from the manufacturers, and you will go ahead and send all your business through us. That's changed a little bit. Those agreements have become really restrictive. If you can see them, if you are able to read them and get a chance to look at them, the rebates have become really restrictive. We spend a lot of time talking about transparency as well. And transparency is very important. It's important to know what's in those contracts. But I would also say that transparency is not a solution. Transparency is a tool, right? So transparency is not going to help you if you are getting a rebate on a drug that shouldn't be on your formulary anyway. If you are talking about what drugs should be on my formulary, what shouldn't be on my formulary, getting a rebate on something, I mean, that's great, but you shouldn't have paid for the drug to begin with. Nobody should be paying for that drug. So I want to talk a little bit about what I mean by drugs that shouldn't be on the formulary. And these are what we call wasteful drugs, or drugs that really don't provide any particular clinical value. Again, I want to make, like I tell people all the time when I read contracts, I'm not an attorney. I'm also not a doctor. I'll probably mispronounce the few drugs I talk about today. But I think it is important to talk about these kind of drugs and how we continue to manage them as we put them on our formularies. The first are these multi-source drugs, where the drugs are coming in from multiple manufacturers, high-cost generics as well. I just heard yesterday that I think Enbrel's going to come off patent and go generic. It's probably going to be a really high-cost generic. Again, how are we going to manage that on our formulary? But more and more pharmaceutical companies are flooding the market with drugs. We also have issues with fixed-dose combination drugs, and let me give you an example of that. For instance, there's a drug called Duexis. And Duexis is 800 milligrams of ibuprofen and 20 or 26 milligrams of Pepsid, right? So you take this drug so you can take a higher dose of your ibuprofen and it won't upset your stomach, right? That has a price tag of about $3,000 for a 90-day supply, right? That's a lot of money. When I could go and get either over-the-counter or prescription ibuprofen and a Pepsid. I mean, if anybody needs one, I have Pepsid in my purse because I get nervous when I talk. So, that's a $20 or $40 cost for every 90 days, right? How are we looking at these drugs? Are we identifying them and talking about them and trying to make sure they're not on our formularies, or at least identifying them? Probably Duexis, they'll give you a huge rebate on that. Well, if you're going to spend $3,000 and get a $50 rebate, maybe we don't spend the $3,000. And then there are things called Me Too drugs. I mean, I think everybody knows about over-the-counter. There was a big push on over-the-counter, right? Maybe we don't even pay for over-the-counter anymore because it's over-the-counter. I can go to Kroger and get my, Pepsid and my, ibuprofen. Me Too drugs, I did start talking about those. That's the trend now where a specific or one ingredient in a pharmaceutical drug, brand drug, specialty drug is tweaked a little bit, and now it's a new drug. And now it's marketed as a new drug. This is the newest and greatest thing. Isn't this wonderful? And there's a price tag that goes along with it. That tweak probably doesn't change the clinical efficacy of that drug. It isn't going to make a huge difference when we're talking about spend. You've probably all seen this slide. We talk about Hep C drugs and Mavorite, also talking about all of the drugs that are available, and Mavorite being, I think it's even cheaper than we have had the slide for a bit now, a couple years, even cheaper than it is now. But Mavorite covers all the genotypes for Hep C. There are genotypes, and you may or may not have to take ribavirin if you take one of the Hep C drugs. There are also on some of these drugs, on some of these Hep C drugs, huge rebates. There are rebates on Mavorite too, but there are huge rebates on some of these drugs, but not worth paying as much as you'd have to take something like Epclusa, right? I mean, these are the kind of things you need to think about, but this is a lot of work. Just as a proposal and a way to think about this, when the Affordable Care Act passed, myself included, for our plan, I'm responsible for MedBen's plan and for questions for with our groups. I spent a lot of time thinking about the benefits on our plan, right? All of the medical benefits, how those were gonna work, how I was gonna apply that, how was I gonna figure out the cost of medical. We need to start paying attention to the prescription drug at a pretty detailed level now if we're gonna control those costs. Oracea, I think I'm saying that right. It treats rosacea, so that's why I figured I might be saying it right. Oracea is doxycycline. It's an extended release doxycycline, right? So I only have to take 1 pill in the morning instead of 2 pills of generic doxycycline. So if I take 1 pill in the morning, I can spend $800 for 30 days. Or I can take 2 pills. I can say to my members, just take 2 pills. Take 1 pill in the morning and 1 pill at night. Be done with it. And it's only gonna cost you 40 bucks, right? This is the kind of detail we wanna make sure we're looking at to understand how our prescription plan is working and why it's costing us so much. So, as I promised, I wanna talk about a few solutions. So the first thing, and this is what we've been talking about, is really understanding the formulary and understanding the rebate structure that goes with your formulary. You need to make sure that you're asking to see the PBM contracts. Look at the contracts. Again, it's kind of like PPOs. PPOs will never show you their contracts with the doctors. PBMs will never show you their contracts with the pharmaceutical companies. But they will. You should be able to see the contract that applies to you. The contract that's applying to you and your formulary and your plan and what you're going to spend and how much money you're going to get back. And if they won't give it to you, that should be a red flag, right? Make certain that in that contract, when you see it, that it describes all the discounts that are coming back to you. I'm not saying that I even propose that that health plans should get all the discounts, although I think that would be super fantastic. If the PBM needs to get some of the money, they need to make some money too. I'm fine with that, but it ought to be disclosed. We ought to know where all the money and all the discounts are going. We also ought to have in that contract reporting. We ought to be able to get reports and data out of the PBM so we know, so we can start looking at this detail very clearly, right, and make some decisions with regards to that. We want to make sure that the contract isn't exclusive. If you have a PBM contract where the PBM itself says you're not allowed to work with any other prescription vendors that might try to save you money in any other way, then that's also a red flag, right? You ought to be able to work with a PBM that says, this is great, this is our contract, and if you want to do some other things, try some other things, that would be great. That's the kind of contract you want to enter into. Again, from a traditional perspective, we want to make sure that we're at least attempting to work with a PBM that doesn't work directly or indirectly or own a pharmacy. Are we pushing people to a specific pharmacy, again, for financial purposes? And there ought to be a termination provision that doesn't leave you hanging financially, right? You ought to be able to terminate that agreement when you want, even if within terms. Let's say you have to give 6 months' notice, but within terms without a financial penalty. We shouldn't have to go through that. Something we've been doing with our clients for several years, and again, this comes from a really technical reading of the Affordable Care Act. Those out-of-pocket maximums apply per plan. They apply per plan. So if I have my prescription and my medical benefits in the same plan, then I have to have one set of out-of-pocket maximums, right? In 2020, that's $8,000, $8,150 for a single, $16,300, I think, for a family. So if I have a Maverick claim, right, that's $30,000, great, it's still the cheapest Hep C drug. If I have that on my plan where my medical and my prescription are combined, then the rest of my drugs for the rest of the year, my plan pays for. I have no copay. I have no cost share because I've met that out of pocket. So we have several clients that have split those. There's a cost to doing that. You need to understand that. If you're subject to ERISA, you may have to have a separate bank account. You may have to file a separate 5500. But one of the things it does is it starts to instill in members that there's still cost sharing with regards to prescription drugs. It pertains to them directly if you maintain that. So it's something to consider. Another thing to consider is implementing comparative effectiveness or working with a pharmacy vendor that can direct you to clinically relevant outcomes. Now, what does that mean? I think, and myself included, until I started thinking about this and we started talking to people, when somebody told me that a drug was FDA approved, I'm like, oh, it must be great. It's fine. It's fine. All that means, if a drug is FDA approved, it means that it was better for that person or more appropriate for a person with a specific condition versus placebo. It doesn't mean it was better than anything that was there before. I think I had in my head that every time something was approved by the FDA, that those drugs got a little bit better clinically. This is a little better, this is a little better. That isn't what it means. It's this test, the standard is always against placebo, which is fine. They get approved, they're all working, but it doesn't mean that those particular new drugs are better clinically. So when we're talking about trying to create a formulary that directs members to the best clinical outcomes, we want to talk about comparative effectiveness. We're talking about comparing the drugs for the same condition and how they work for people directly. Are they clinically effective? Are they doing what they say they do? In some cases, that means that the drug that is the most clinically appropriate could also be the least expensive. And I want this to kind of sink in a little, because it took me a little bit of time, because I had this mindset about the drugs being approved. But we're not talking about finding similarly effective drugs for a condition. We're talking about finding the best drug or a more clinically appropriate drug for a condition that in many cases is lower cost. In some cases, I'm not going to steer you wrong. In some cases, it might be more. But that means that I'm taking the appropriate drug right off the bat. I'm not spending time taking a drug that doesn't work or doesn't have the same efficacy for my condition and then move to a more expensive drug. I'm getting clinically appropriate care right away. But again, this takes some time and some effort when you're looking at your formulary to try to develop and understand exactly what those drugs are, where they are on your formulary, if you can get a rebate, if you're allowed to carve out the ones that aren't clinically appropriate. How are we going to manage all of that? The other thing I want to talk about quickly is mail order and working with manufacturers' coupons. And both of these things sort of independently have come up. You know, when I first came to MedBen, which was a long time ago, I've been there for 28 years, but you know, I can remember it was sort of the onset of mail order, and mail order was this great thing, and you got the drugs delivered to your door, and the clinical ability to make sure that your members were taking drugs, you know, was seen to be greater because I was getting the medication. Doesn't mean it was actually going in my mouth, but it was coming to my door, and apparently I was going to take it. And now, so over the last few months, and particularly after the onset of the Affordable Care Act, mail order has kind of gone away. We don't, you know, when we're talking about out-of-pocket limits, we're talking about copay and cost share. Whether I get it at the retail pharmacy or the mail order pharmacy, it's still cost sharing. I'm still going to blow through my out-of-pocket max if I have a medical condition, generally speaking. Now, you know, with the advent of manufacturers' coupons and the IRS backing off their sort of sit on the fence position about whether or not we can actually use the manufacturer's coupon as part and not apply it to the out-of-pocket. So the IRS was on this fence for a long time about if the manufacturer came in and paid for the drug and they paid for the majority of the drug, that needed to be applied to the member's out-of-pocket. And I'm like, well, that is just ridiculous. That wasn't out of the member's pocket. That was out of the pharmaceuticals pocket. So now the IRS, thank goodness, seen the light, lots of comments on those regs. And so now we don't have to do that, and that's great. And so now we can sort of look at manufacturers' coupons in a new way. We can start thinking about how we're going to use them. And one of the things we can do, we've been talking to some folks that have sort of tied the two together, mail order and manufacturers' coupons. At this point, it needs to be voluntary. Again, we have you know, an issue with regards to benefits and HIPAA and those sort of things. But if you incentivize somebody to to get some of those specialty drugs, or at least those drugs that have manufacturers' coupons, through the mail order. This mail order pharmacy will work with the manufacturer and the member to get that covered. The plan will pay what the plan pays, the manufacturer will pay what the manufacturer needs to pay with the discount, and the member will pay their cost share. And it seems to be sort of that we're working closely to, again, manage that formulary in a way that saves us some money. But I think that the big point that I'd like to make with regards to pharmacy and formulary is that the days of just signing up for a PBM's formulary are over if we want to really try to control a cost and have the best clinical outcome for our employees and their families. It's a lot of work. You have to find a vendor who's willing to give you data, who's willing to have you look at that and give you outcomes and information with regards to not just your spend, but the drugs that you're spending the money on and what other drugs might be available, trying to look at the creation of formularies where we might take advantage of the Affordable Care Act that says, I only have to have one drug in every therapeutic class and category. I might have more, but I only have to have one. How am I going to do that? How will I manage that formulary to both meet my employees' needs and my plan needs and my future employees, right, as a benefit? We're still offering a benefit and trying to entice and incentivize people to come work for us. How am I going to do all that? And it's data and reporting. And so understanding what those contracts are crucial with your PBM. So are there any questions? Yes?
You may not be able to answer this, but
So,
try anyway.
okay,
So
all right.
the administration's recent directive about purchasing drugs,
Yeah,
and
yeah.
what we're going to purchase in the future, how do you see that playing out in retail plans like this?
Well, so right now, the administration's executive order with regards to the cost of drugs and, buying them from Canada or whatever, those kind of things are applicable mostly to Medicaid. They even said if it's going to be available to Medicare, but government-sponsored plans in particular, the information I saw was applied to Medicaid. So I think one of the things that happens is if it works and it saves money and it doesn't cause sort of other economic disruptions, and we don't have a huge backlash from the American pharmaceutical companies, because that's what's going to happen. Yeah, once we get past all that, I think it could play out and trickle down, and certainly it will want to. A lot of the large Medicaid players are also the large insurance companies in this country. If they're going to if they see that they save money there and they can save money on their drug spend as well, it'll start filtering down. But there's quite a bit of opposition, obviously, from an industry perspective. So we have a ways to go. But it's going to be interesting to see how that plays out. Anyone else? Well, I want to thank you very much for your time. I greatly appreciate it. I'll be around if any questions come up, or if you want to correct my pronunciation on any drugs, because they're all bad.
Thank you, Caroline. If you have a question, please be patient and raise your hand and let them bring the mic to you to ask it, because we have about 100 people watching us or so live. So we won't be able to hear the question that is asked. Our organization, we always feel, tries to do things a little bit more uniquely, in that we consider hospitals our friends, not our enemies. And when we treat them that way, they turn out to be our friends, and we can make appropriate relationships with them. One of our local hospitals, St. Elizabeth, has been partnering with Sherrill Morgan for a number of years in order to be able to bring a direct contracting relationship between you as the employer and St. Elizabeth. So it's not required that you have to use a traditional PPO or insurance company in order to have that relationship. The gentleman I've worked with for all those years in doing that is Mr. Bill Banks. Mr. Bill Banks today is going to kindly talk to us about the impact of COVID in our hospital systems. Thank you, Mr. Banks.
Yeah, we're not going to talk money like I usually talk. So before I begin, how gratifying is it to spend time with World War II vets? I mean, for me personally, I was a Xavier ROTC graduate, And immediately upon graduation, I went to Germany to spend 3 years with the 1st Armored Division. I love stories like that. I could just talk to him all day. I left the Army 30 years ago this summer. God, it's probably before Kyle was even born. So pretty close. So today we're going to talk about COVID a little bit, more about our experience running a business, a healthcare business during the COVID times. That's really what I want to talk about. And sort of, yeah, it's been rocky, but we've gotten through it, and that's what I want to talk about. Certainly happy to take any kind of questions, so interrupt me as you need to. So, yeah, about March 18th, remember the governors of Ohio and Kentucky asked us all to please shut down our businesses, if you wouldn't mind. And us hospitals said, well, what do you mean? I mean, we do a lot of really important stuff. And they said, we don't care, shut it down. If we, the basic rule was for the preservation of life or limb, you can do services. Anything else, you got to shut it down. And so that's what happened to us. All of us who are in the hospital and physician groups, so we run a 1,000-bed hospital along with a physician practice of about 600 multi-specialty providers. So we're everything. In Northern Kentucky, we're all the primary care, we're all the hospital, we're all the surgery centers. We shut it down. Pretty much we shut down about 94% of our outpatient surgery for a period of about 2 months, from about March 18th to June 1st. We were essentially out of business in some parts of our organization. And you have these slides in your handout too. I know this can get a little tiny up on the screen. But so we would normally be doing 3,000 to 3,300, 3,400 admissions per month. That came down in April, for example, to about 2,300 admissions. So we lost, a big part of our revenue generating capacity. What we did not lose was our costs. So it still costs what it costs to run a hospital, same as a lot of businesses out there. Hospitals are big bundles of fixed costs. We got property, plant, equipment, salaried nurses. I think we were alone in the tri-state making the decision not to lay anybody off. So 100% of our workforce, we committed right up front to say, as long as we can do it, we're going to keep you guys on salary. We may have you doing different things. You might be taking temperatures at the front door. You might be helping with the supply room, getting our masks and gowns done. But nobody's going to get laid off. And that really has allowed us to come back. Now that we're back, I was talking to Kyle over lunch about this, that a lot of hospitals in the tri-state are now having a hard time staffing their ORs because they laid their operating room staff off. Well, they're the highest paid nurses in any hospital. So they were the first people that a lot of hospitals let go. Well, turns out that now that surgery's in great demand, we can fulfill that demand because we've got our staff. We didn't let them go. So, the blue line there is last year's admissions per month. The orange line is this year's. So we're coming back. We're about, I would say that we're close to 100% on some lines of business, not all. And people ask me all the time, well, but you replaced all that. You had all these COVID admissions, right? Well, not really. So we dropped about 1,000 admissions in April. May was our biggest month for COVID admissions. We only had 168. So we were not really taking in a lot of COVID patients. We just stopped taking, surgery patients that didn't absolutely have to be there. Of course we did. We delivered babies and we did surgeries that had to happen. But as you can see, a whole lot of stuff didn't have to happen in those months. And people ask me all the time too, isn't it true that you receive more money for a COVID admission? Under Medicare rules, that's true. So a Medicare patient who was COVID positive, yes, we were receiving a little bit more money, still do, but it was nowhere near enough to make up, what we were losing in the other parts of the business. So you hear it a lot during the worst part of the crises, April and May, I guess. We were hearing all sorts of horror stories about New York City and other places where there was real capacity problems. We were sending, the U.S. Navy ships up to New York Harbor. We were, erecting tents. We were doing a lot of things. We had contingency plans for using the Northern Kentucky University not auditorium, but the BB&T arena. We were going to use that as a field hospital if we needed to. So our facilities folks were in there scoping out where's the electricity, where's the water, those kind of things. Fortunately, we never had to do that. We never had real capacity problems in our region, and most regions probably, could tell this story. This is a report that comes to me every day, comes to our whole leadership every day. It's just a tracking of how are we doing? Are we full? And every part of our hospital system reports up. So The one on the left there is May 1st. That was probably our worst COVID day. We had 85 inpatients on that day and that were positive for COVID, and with 32 that were suspected. You have to treat them the same. A suspected COVID patient, until they're ruled in or out in terms of diagnosis, you have to treat them that way. So all the safety protocols, all the protective equipment have to be used in treating them. They have to occupy separate space, et cetera. We designated one hospital, our Fort Thomas campus, as our facility where we were going to treat COVID patients when they came in. And that actually was a blessing, because it allowed us then to keep all the patients that were not COVID in the other facilities, and it kept us going pretty well. It also allowed us to do things, I don't know if you recall, there was a couple different, well, more than two skilled nursing facilities, long-term care facilities in the Northern Kentucky area, and really all over. That's where COVID really hit us hard. Rosedale Green was, anybody here from Rosedale? Oh, okay, so Rosedale Green was one of those. I can mention them because they made the papers. There was others that I don't think, so I won't talk about them, but they were particularly vulnerable to this kind of thing. They did not have the right kind of protective equipment, not enough distancing between patients, not enough training for the staff. There was a lot of things that were, moving against them. They couldn't afford to hire the best staff, for example. And that's just true of the long-term care industry generally. And they were also vulnerable in the sense that as soon as the COVID crisis started to hit, they were losing staff. Their staff just quit. They, just saying, I will not work here anymore. So they were short-staffed. We were lucky enough we could jump in and dedicate a lot of our nursing staff to those facilities. So we immediately put our staff into a lot of those nursing facilities. In a couple cases, like with Rosedale, we physically went and took residents out of those facilities and brought them to our Fort Thomas facility. So literally in the dead of night, one night, we took a whole bunch of people out of Rosedale and brought them to Fort Thomas. A lot of people died during that crisis that Rosedale went through, but a lot were saved because we just said, it's going to cost us a lot. We had a wing of the hospital we could open up, a disused wing, open it up. It took us about 8 hours, but everybody pitched in and just got it done. But even through all that, even on our worst day, you can see our ICU bed capacity was only at 17%. We were only 17% there. Our total ventilator breakdown, we were only using 24% of our available ventilators. And that was pretty typical of most hospitals, especially in the Midwest. We thought ventilators were going to be in very short supply. Didn't turn out to be the case. The graph on the left that was last week, where we were down to 21 positive. This morning's count was 15 positive. So it's message and 2 suspected, I think, this morning. So we're not out of this. We're treating this as we're not out of it completely, but we are now at a place where we can get back to kind of normal business. So that's been a good thing. On the physician side, remember I told you we have a 600 physician group. So we should be doing about 5,500 physician office visits per day. Well, March 18th, the governor said, shut it all down. And literally most of our physician practices simply shut their doors because we decided, no, it's not something that preservation of life and limb, we can't do it. So that's the blue line that you see, the actual in-person physician office visits. Those went from about 5,500 a day down to about 500 a day. And it crashed pretty quickly. The gray line that you see, and maybe it doesn't show up as well, but it's on your handouts. Those are our telehealth visits. So we were one of those that we had been experimenting with telehealth. We had the capacity, we had the ability to turn all of our primary care guys on pretty immediately. So we were lucky in that regard. We had been pushing it amongst our staff, but there were some barriers. My staff physicians didn't really love doing it last year. Insurance companies generally didn't want to pay for it last year. And patients didn't really love the idea of doing a telehealth visit. Well, March of this year hits, and of course, the whole game changes. The office is closed. You can't come in. And the insurance companies, broadly speaking, said, yeah, we'll pay for it. Led by Medicare, and I give Medicare a lot of credit in this case. They led a lot of this stuff by simply saying, we will pay for it. I don't know how we're going to afford it, and I really don't know what the rules are, but just we'll pay for it. So, and that was pretty typical. A lot of insurance companies broadcast to us, we're going to stop denials, at least for this period. We're just treat the patients. We'll figure out stuff on the back end. So I have to give credit where credit is due. Some days I don't like dealing with Medicare at all, but in this case, they really stepped up. So the gray line is telehealth video visits, the orange line is telephone visits. So we went from about 2 per day on our telehealth up to about 2,000 a day at the peak. But you notice what's happened as we've kind of gotten back to work. So as you go, that dip down there is Labor Day. So this shows every day since, and we are almost back to 5,000 visits a day in person. We still have the same ability to do telehealth. We still have essentially the same payer rules. Payers are willing to pay for it. But now that we've reintroduced the alternative of you can come back to the office, patients uniformly say, oh, I want to come back. It's been an interesting thing. During the height of the crisis, everybody was thinking, hey, maybe we're never going back to in-practice medicine. Maybe telehealth is going to replace this entirely. No, I don't think so. I think what we suspect is we're going to kind of level out at about 10% of our activity is over video or telephone visits, and that's where we're going to kind of settle out. And it's still the same dynamic. Patients don't really love the experience. It's certainly if you have a 90-year-old patient and it's really difficult to get that patient into the office, it's a great alternative. But it's just not the same thing. Physicians also don't love it. It turns out physicians don't love it because they spend at least half of the visit, almost everyone, being the tech support for what do I do now? The volume isn't working. I can't. So it's frustrating for the physicians. So there's a lot of I think introduction of new technology generally was helped. So we've introduced it. Every one of our physicians has now used this technology. But you can't get past the fact that they're all comfortable doing it the old way. So we'll see what happens there. We'd be very happy to keep doing it. So let's talk about the real financial cost. So I told my boss I would not put these numbers on a slide, but I'll tell you what they are. So we were down $125 million revenue. So it really cost our system, all this lack of activity cost us about $125 million over that period, March through about middle of June. The federal government came and helped us quite a bit. They gave us, and this is Medicare, you've probably read a lot about this, Medicare gave us about $170 million. 70 million of that was real grants. That was what the Congress got together and said, hey, we're just gonna push a lot of money to businesses. We were one of those businesses. We received about 70 million in actual grants, don't have to pay that back. About 100 million of that we will have to pay back. So the legislation that was just signed by the president, I think yesterday, gave us some relief in paying that. Originally it was to be paid back this year. So we were gonna get, we got $100 million in the first half of the year, great, that let us make payroll, et cetera, but it had to be paid back by the end of this year. So we were sweating it, like a lot of people. So do the math then. I've got a $70 million grant payment against a $125 million loss. We are going to experience about a $55 million shortfall on our operating income versus budget. So I'm not sure if we're going to make money. We probably will not make an positive operating income this year. And like a lot of hospitals, the board got together and just had to swallow hard and say, that's why we have rainy day funds. That's why the community has given us the excesses over the years. We're going to dip into our savings account, basically. That's what most community hospitals have had to do here. We did it without having to lay off staff, and we're very thankful for that. Other hospitals, not so lucky. So you've probably read, we will be running Dearborn County Hospital effective November 1st. So effective November 1st, Dearborn County Hospital in Lawrenceburg, Indiana, just to the west of us here, they were one that was kind of teetering financially at the beginning of this year. So they already were in financial straits. They're a small hospital, less than 100 beds. They only run 3 operating rooms. For any of you in the industry, outpatient surgeries are what really float our whole industry. That's where the profit lies. And small hospitals like that have a really hard time keeping people in the community, staying at your hospital to do those surgeries. And they just don't have the staff to run anymore. So this hospital was already in trouble. We were helping them with their business practices at the beginning of the year. COVID hit and it smacked them completely, to the point where they weren't going to be able to make payroll by the end of this year. So, so that is a real thing, and watch for that to happen as we go through the rest of this year for a number of hospitals. Let's talk real quickly about the other cost of this whole thing. That is the cost of not getting care. So this is a chart for our Medicare membership. We typically want to see 80% of those members, our Medicare members, every year for an annual wellness. As you know, the annual wellness visit is a free benefit for Medicare seniors, and we really insist that you come in and get that. We are used to doing about 2,000 a month, or about 3,000 a month. We're trying to get about 80%. The normal number of this for most Medicare population is about 15%. So we do a very good job of it, but you can see that during April and May, it crashed off to nothing. If we can't see you every year, we can't diagnose conditions, we can't recommend the breast cancer screenings, the other cancer screenings, et cetera. So we are running like crazy to catch up. That's really what I wanted to impart this message to this group here today. We missed a lot of those kind of screenings and wellness visits in the second quarter of this year. Our mission in the third and fourth quarter of this year is catch up. And you can see that, in those other months, we're up to about 6,000 visits. So we're going to get there, I think, on the wellness screenings. So anybody know what today is? Today starts, this is October 1st, it starts Breast Cancer Awareness Month. So we are typically real busy in the fourth quarter of the year on breast screenings. And it starts in October, then we kind of continue in November, December. We have an annual goal of 80%. We hope we're going to make that, but you can see, it's the same as everything. Why is that important? Well, it's important because we've got about a 2% find rate. That is, for every 100 women that come in and get a screening mammogram, 2% of those women, we find cancer in them, and that we can't treat. Breast cancer is no longer really a death sentence in this country, mostly because we've got an aggressive, early and often screening program. Well, if you stop coming in and get screenings, or you miss this year, you say, well, I'll get it next year, reasonable chance that we're going to miss some stuff. So that's what got us very concerned. We're racing to catch up on this one as well. Same with colon cancer screens. You can see that our goal there is 80% too. We're probably going to miss that goal, but we're striving to get there as quickly as we can. Here's something, I wanted to highlight this. So what you see here is we got real aggressive this year in other ways to treat this issue. If you can't come in and get the diagnostic or that colon cancer screen, that colonoscopy, well, what else can we do? Well, Cologuard is a kit that we can send to your house, and you use it, and then you send it back. We sent out, we engaged 13,700 patients this year, unique patients. We sent out, in collaboration with Cologuard, the company, we sent out 6,300 tests this year. 450 of those came back positive. From those 450 positives, I'll just highlight the yellow arrow in the interest of time, but 150 people who are, returned a positive Cologuard test showed up as, oh, you've either got precancerous lesions or you've actually got cancer. So here's a case, here's 150 lives we just saved by saying, hey, even if you can't come in to get your colonoscopy, let's get this done. So this allowed us to continue to remain engaged. This counts as a positive, on our screening process. Diabetic retinopathy screening, same thing. If you're a diabetic, we really are looking at your eyes carefully. And and here's one, it went almost to zero, you see, in the bad months, because we really have to do that in-person physical exam. There's really no alternative to that, at least not yet. Maybe someday in the future. Same with lung cancer screening. We are now one of the leading hospital systems in the country in terms of screening for lung cancer using low-dose CAT scans. So it's actually a very cheap test, doesn't take much time. If you're you have to be a 30-pack-year smoker, but this is a free benefit now in pretty much all insurance plans. And again, it's about a 2% find rate. So for every 1,000 patients we're scanning, we're finding 20 cancers. So we want to keep that. And just to sum up, here's just a chart that kind of gives, here's how we're doing. So systems like ours are kind of racing to catch back up. We want to be at an 80% compliance with most of these things. We take that very seriously because we know that every 100 screens we don't do, that's 2 people that we didn't find their cancer. So it's very important for us to get this done. So if you're one of our patients, you probably are getting engaged pretty aggressively, saying, I know you couldn't be in the office in the second quarter, but you've got to come back in in the fourth quarter at some point. So that's all I had. We're like most hospitals. We understood that this was going to be financial pain, but we just kind of swallowed hard and said, all right, whatever it takes, we've got to get back to the real mission of what we're doing here. Now that we're able to get back, it has been expensive. It's been hard. We've learned a lot. I think we're going to come out of this whole thing stronger than we were. Is there any questions I can answer for anybody? Yes, ma'am. Oh.
once you were able to have surgeries again and things were opened back up, is there a huge increased cost in having to set that up? And
Right.
and how much does that cost? Not how much does it cost, but I mean, from a percentage perspective, is it exorbitant, or is it something you're going to continue
would
to
say-
do, or we've learned
Yeah.
from, or?
Our cost across the whole enterprise has risen because protective equipment now must be used in a whole lot of places where maybe we didn't before. Registration staff and in the operating rooms themselves, it's pretty much life as usual. Life as usual because that's an environment that has to be sterile. Everybody's already got that protective equipment. The N95 masks are what they normally do. So for the ORs, it's not much of an incremental or marginal cost. For everything else in my system, yeah, we're like every other hospital system. We can't find enough gloves, masks, gowns. We're getting there, and we've had to kind of reuse masks to the extent we're allowed to, et cetera. Most of that stuff is behind us. The incremental cost is with us, but I wouldn't say it's huge. It's certainly, it pales in comparison to how much I'm paying for drugs, for example. But, it's going to be with us. I don't think we're going to go back to the days, at least not until we get a vaccine that's spread throughout the country, will we go back to the days of no mask, for example? I think that's just business as usual now. Anything else? Thank you.
Hi, y'all. I'm Shannon Mason. You may recognize me, a lot of you here in the room as well as on the phone. I used to work at Sherrill Morgan, and I was there for about, almost 12 years. So I'm very, very proud to be here today, but I'm on a different role now. I work for HealthStat. We're a worksite, on-site health and wellness center. We do a number of facets, including shared use in virtual care centers as well. A lot of the information that Bill just talked about is near and dear to my heart because we're constantly trying to make health improvements for our members and also health maintenance. Our motto is, how healthy can a population be? And so with the fact that we're deferring care so much right now, we're finding that we know that these gaps in care are not being closed, and the cost is going to rise over time, and the population, unfortunately, isn't going to be maintaining their health. So there's a number of different areas that we're helping organizations with. I love to say, too, besides just worksite health and wellness centers, our firm is also doing standalone health improvement activities surrounding diabetes management, cancer programs, managing that. Like I said, virtual care centers of excellence is another area. And then the one that is very near and dear to my heart, too, is mental health. Whether you do it inside your primary care providing some care or worksite health center, or you need some help on a standalone basis, all of those areas are things that I'm seeing a lot of need in the community right now and something that we're trying to help and address. And if you ever have any interest in those areas, please feel free to keep in touch with me. But we are your break sponsor, HealthStat. Again, very privileged, proud to be here. Get to know and see all my friends and former clients. And so we have a break coming up here. It's about 10 minutes. Please enjoy yourself, and we'll be reconvening in about 10 minutes. Thank you so much.
Give everyone a 1-minute warning here before we begin again. 1 minute. All right, if we can everyone please have them take their seat, we'll begin again here so our online people will hear everything. Yeah, really. Amanda, if you could help us have everyone get their seat. All right. If you were with us last year, you were there for our 50th anniversary celebration. That is where the banner behind me came from that we're using here today. And our 50th anniversary, we had a gala that evening as well. It was quite the party, and those of you that were here, we were there last year, we're glad you're here again with us this year. I was about 7 years old, I think, when the company started, just over in the corner over there, working with my dad. And right away, at about the time he knew that he could trust me regarding my ABCs, he had me come in and do index filing cards. That was a technology system back then you all may not be familiar with. It's index cards in the little plastic boxes and metal boxes you'd put them in and organize your customer names. And of course, then I was also in charge of making sure that the Rolodex, phone numbers, what you would do to make those calls and all. But obviously things have changed throughout time, and it seems like I never left the company. I'm still working there today, and I still have to take care of the Rolodex. But he starts a system, he never leaves it. That's one of the reasons he's always been so good. Thank you all for being here. What I'm going to talk about today is obvious on the surface, but not in reality. And that's trends in healthcare because of COVID, what's happening, what's changing. And you would think that some of the more significant changes we talk about would be things like telemedicine, and Bill just talked about the fact that about 10 to 11% of their population, their meetings are telemedicine. I think we have some other industry situations where that might be a little bit higher, maybe in the clinic space, on-site clinic space, stuff like that, maybe a little bit higher telemedicine rate. Adopted more than before, but still not to any dominant circumstance that we'll be having all of our visits take place to telemedicine. Rapid testing, not only because of rapid testing from COVID, but all testing now is just a little bit faster because they're geared up to do more volume. Well, it will slow down because of COVID, but our abilities to do faster testing have increased. And what we can test for, the labs and the technologies that are in place here today, and one of our lab partners is even with us here today, Gravity. Pharmaceuticals, Caroline talked about the expense of high-cost substances. The delivery systems, of how we get those have changed. Those kind of things are significant. Wellness. Wellness obviously took a hit during COVID. You couldn't have your exams, but let's just talk about wellness a minute. And really, I think one of the major trend changes that we're going to see is because of wellness and not because of wellness. If you think about a wellness program, they have taken the individual and they've looked at your blood. They've looked at your pulse. They've looked at how well your cardiovascular system is working. They've looked at your sugar. They've looked at, if you're going to be a diabetic or not. They're trying to give you an outcome to what they think is going to happen to you in the next few years if you don't change your behavior. If you keep up the drinking or the smoking or the partying or the other things that we won't even go into that I've had to give up, then you begin to realize that they know everything about me they could possibly know. I went to Johns Hopkins last week and I said, my big question was, what can I do to improve my longevity? That's what I'm after. What can I do to live longer? Well, we're not sure. We can tell you how to live healthier, maybe. And I said, okay. But that's not what I'm after. I want to have a healthy, long life. Because I happen to love the people I get to hang with around it every day, and if I'm gone, no one's going to be around to take care of the Rolodex. So, in all of this, when we know more about ourselves, are people really still improving their health condition? Well, we have the nursing homes full of elderly that need constant assistance. My body continues to break down. So information about myself apparently doesn't entirely seem to be the key to long life. I'm not saying it's not valuable. I'm not saying it's not meaningful. But to a healthy life, what's the missing piece in our wellness programs that we're missing? COVID brought to light, I believe, not new problems, but you know how when something breaks, you say, why did it break? It amplifies an underlying situation that was already there, already present. And we're trying to work through what is happening, what broke. Well, did any of these situations, according to the CDC and mental health evaluation during COVID, are any of these circumstances new? Anxiety, trauma due to stress, and like anxiety because I'm at home all day and I have to be with her every single minute. Actually, it wasn't so bad for me. I kind of liked it. I've only been married for 3 years. She's in the room, so I have to kind of like walk that back a little bit, you know. I've only been married for 3 years. But I found out I like my wife more than I thought I did. And I not only want to marry her, I like living with her, you know. It's like, gee whiz. So, but depression, anxiety, things changing our lives because of that. Trauma, stressors. I couldn't go get my therapy done, all that kind of stuff. My back hurts. My knees aren't working right. Increased consumption, substance abuse. Increased substance abuse. I talk to all my friends that drink, and they say, we're all drinking more during COVID because it's like, just like that self-administered treatment that you're taking because of the other stressors. So that's not good. And then considerations of suicide are up dramatically. None of these COVID caused. COVID took an underlying issue and amplified it. It's always been there. How does your health plan address these things? Really, is it the health plan's responsibility to be addressing these things? We have been talking about how to get, your prescription drugs cheaper, how to get more information about yourself and your wellness program so you're better informed. But maybe we're missing something. Communication with people. This is the new norm. My goodness, I don't know what Zoom meeting this is, but I wouldn't want to be on it. I mean, can you imagine how they're talking over one another? And we've been forced to communicate in this format. And in our culture today, even with my sons, I have I have 5, how many sons do I have? 6 sons and 8 children. All 6 of my sons, except for maybe one of them, communicates more by technology than any other format. My youngest son is a pseudo music star in Nashville because his, what's that website for music? Spotify, yeah. He's gotten on that, done the situation where he's got thousands of hits a week. He's never met a single fan. He doesn't know who they are, other than that they're online music fans. So that online communication is turning out just like it's not a replacement for our doctor. That technology communication is not a replacement for our everyday lives, our social circumstances. Could it be that this is the thing that we're missing? Could this be the answer to longevity? That our social close-knit population that experiences a cultural conveyance together through life, is that maybe what we're missing? When we think about studying illness within our own culture, we study it in economically disparaged communities. We say people that live there are unhealthier because of their economic status. But they also have fewer fathers in the home. They have fewer community functions to go to. Unemployment tends to be higher. There's a connection missing in those situations. Maybe we're studying the wrong thing. And a look at longevity in what was called the Blue Zones. The Blue Zones was created by a gentleman, what do they call it? This is where I should have had my notes up here. A National Geographic writer
who suddenly just took the term blue zone and called it blue zones because they were studying longevity around the world. And where do people live the longest? And from there it became a term also called centurions, not Roman guards, but people like the gentleman we had this morning speaking was a centurion because he's lived 100 years. Does his body break down some? Yeah, sure, but did you notice he stood and gave his presentation at 100 years of age? My father wants to be a centurion. I believe he's going to make it. He's still working at 86 years of age. I know every day I have to check the Rolodex. So when we looked at these, they looked at these different areas, and why did people live so long in these communities? Obviously, they have amazing wellness programs. Obviously, they have terrific health care. There can't be any economic disparity. Well, definitely not in Loma Linda, California. There's no economic disparity there. But, you know, there can't be. So these places must be just amazing places to live with great health care, great wellness, you know, great technologies. Two doctors, I can't even say the name, and it's a great book. You want to look into it. But De Nicolantonio, doctor, we'll just call him James, and Dr. Fung went and studied these blue zones, and in a book that they intended originally to be consumed around diet and what people ate, turns out that it just kind of began to verify what we suspected, that socializing and maintaining tight-knit communities also plays a significant role in longevity, says the doctors. The healthiest people in the world don't eat in front of the TV. They eat with their family and friends. They linger over shared meals because they are enjoyable. They don't grab a quick bite simply to eat. And again, they say, oh, did I skip a quote there? How do I go backwards? Oh, it's the same thing? Okay, although these people live throughout the world, and we saw that earlier on the map, with seemingly widely divergent diets and lifestyles. They went out there to study diet. And they said, no, wait a minute, their lifestyles and their diets are vastly divergent. They all share certain characteristics that might help them live longer, fuller lives. These people often smoke less, move more, and not with treadmills, at moderate levels, and prioritize family and socializing above all else. Family and socializing, close-knit communities, interaction with human beings. In our society, the only reason I kept this on me is because, when I normally take it off me, is because it's exactly what our society has become. This is, I have to, my wife and I have started this thing where I literally have to set it in another room when we go to bed at night, because otherwise it becomes a part of our morning operation, our evening bedtime situation. It interferes with socializing. You know, the TV is not my friend. It's a distraction, but I treat it like one. Oh, I gotta watch the evening news. You know, is Tucker on yet? That's not interaction. I think what we may be missing is when I think about, I'm trying to go backwards here on purpose. When I think about this, my wife and I started going to church again. It was completely by accident. We went to church our whole lives. And then we just stopped for a while. You know, we had better things to do on Sunday morning than go to church. Well, I don't know if they were better, but it's church, but they were good. We went to the church down in the park. So COVID caused one of our largest community churches to have to shut down. They said, we're not going to stop having service. We're going to take over the Serpentine Park, what's it called, the Aitman's Cove. And we're going to have our service down there. It gave me hope. COVID caused people to do something different. They went and got together in large places wearing masks and social distancing, but over 2,000 individuals were down there at church. And you know what? It wasn't my grandfather. It wasn't my mother. It wasn't my father. It was also my mother, my grandfather, my youngest child, my friend of my age. But the number of 20-somethings and 30-somethings were overwhelming. We notice that it's missing. We notice that it's missing. And we have to find ways in our communications and work lives to say that when we talk about our wellness programs, where's the page that asks about your interaction with other people? Where's the page that says, what's your planned weekly social gathering, whether it be a religious event or Rotarian club or the JCs, you know, those organizations are plummeting in membership. The youth are not participating like they used to. Why? Because they think this is socializing. This is a cultural change in our society. We need to stop thinking of our wellness as an economic tragedy that we have to address. It's economy. Obviously, it's the money. They're in a poor community. Well, what about that map again? South America had a blue zone? Yes, diet was important, but above all else, they prioritized family and socializing above all else. Now, I'm a Bible guy. I read the Bible. I read it every single day. And particularly if you read the Old Testament, it can be really boring. Old Testament, this is the Bible. But every bit is like, this is when you get together for this festival, and this is how you socialize at this festival, and this is how you come together for this festival, and these are the ceremonies you'll perform at this festival. Interaction within our society has been a historically important function of what we do. And to think that social distancing is now the appropriate measure of relationships, I think is a fallacy in the way we're thinking. This too shall pass. This too shall pass. And 100 years from now, you know what? We'll do it all again. And 100 years later, we'll do it all again. But we have always succeeded because we live in close-knit communities. Parks. I mean, just the way we used to think about things is the way we're going to think about things again. But this underlying problem that we've had of mental health, I think we need to begin to realize that the mental health is part of the community that we are in, the interactions that we have, that family is important to long life, that having a constructive home with parents raising children is a constructive way of life for longevity and health. Not saying what kind of parents they have to be or what kind of organization you have to be a part of, but if what you're doing is meeting with your friends at a bar and entertaining yourselves on the weekends, but you don't have other social circumstances you're involved in, commitments that make you go, gosh, do I have to do that again this week? Wish I could miss Rotary this week. You know, it's every freaking Tuesday. You know, you got to go all the time. You know, it's a part, turns out it may be a part of longevity. So I look forward to us reevaluating things and looking at mental health and longevity and wellness programs as what else are you doing in life? What do you do besides work? And if work is your social function, how do you socialize at work? How does that improve your close-knit community? How does that make you a better member of a family? This is just a community table. It's not even a family dinner. It's just a community table where people eat as a community at the table from various different backgrounds and cultures. It's a part of what makes us special. It's a part of what makes us unique, that we are interactive individuals and that we find ways to communicate better. Our religion, whatever it may be, should be very important, a central part of our life. Our family should be a central part of our life. And we need to begin to realize that that is a part of wellness. That is a part of longevity. To have those structures and important people to us bring them closer during this time. Mental health and the issues we saw from the CDC when it was measured during COVID won't get better until we realize as a society that wellness is not necessarily technology. It is not necessarily information about my inner physical being. It might be more important about who I am as a person and information about me individually. So I think a place for the social psychologist to be a part of our lives is maybe an area that we should begin to investigate more. What do you do with your social life? Some people don't have issues with it, but apparently a great many do. And I'm afraid it's our youngest generation that, thank God, has not had to go through a Beaches of Normandy situation. But they've also stopped going to community activities such as the Rotaries and the JCs and those organizations dropping the membership. They've also stopped going to churches, but thank God it seems like they're reinventing that for themselves at some level. So just a different way to think about longevity and long life. By the way, the other 50% of that book was called The Longevity Solution. It is really all about diet, and it's really kind of fun to read. But when you're seeking to find one problem, sometimes you find the solution to another. So that's kind of my message today. That's the wellness situation in life, and that's our health plans, no matter what the premium is, can address sometimes the most underlying problems to how long we live or the way we live. That's all I have. Thank you. If there are any questions, I know that's more of a what your preacher might hear say on Sunday. I don't know. so much about questions. But I would recommend the reading Longevity Solution by the two doctors that are on the screen there. Our next speaker is one of the services that we have provided in our health plans in the past has been pharmacogenetic testing. And we've had an organization we've worked with for a number of years called Genetics for Health. We've recently turned that over to an organization called Gravity Labs. And Gravity Labs, who's got a great resume for things like working with Kroger and other major entities, is taking that over for us. And we're going to have, this is Brian and Jennifer from Gravity come up and talk to us about the pharmacogenetic program and what's transitioning to within those health plans that have that in their health plan today.
Hi, everyone. My name's Jennifer Goff. I'm VP of Sales for Gravity Diagnostics. Thank you so much for having me today. We're very excited to provide the services that we offer as a laboratory. We're based here in Covington, Kentucky, so we're local. And I'm going to run through all of our services as a laboratory. I'm going to try to be brief. I know that pharmacogenetics in the past has been the primary test that we've offered in partnership with Sherrill Morgan and Sherrill Morgan's partners, but I'm going to do a brief overview of all of the testing that we offer at Gravity Diagnostics. So as I mentioned, we are a full-service CLIA-certified laboratory, and we are licensed in all 50 states. Our big thing is we're an advocate for physicians, patients, and our communities, supporting them with unsurpassed integrity, regulatory compliance, and clinical expertise. So our CEO, Tony Remington, this is a photo of him in one of the many media sites that we've been featured on since the COVID-19 pandemic. So throughout our journey with COVID-19, our impact has been recognized by Forbes, the Washington Post, CNBC, and more. We've rapidly expanded. We've added over 100 additional personnel at our laboratory, and we've actually expanded our laboratory space. So we now have an additional laboratory just 2 blocks down from our primary laboratory. We've been able to secure many partnerships, Kroger Health being one of the biggest one. We work with over 300 nursing homes and long-term care facilities in the state of Kentucky, over 100 hospitals, so we are rapidly expanding our client base. So this just goes over our COVID-19 tests that we do have available. I'm not going to bore you with some of the details and the science behind it, but we do offer COVID-19 by real-time PCR as one of our main assays. We have also developed high-throughput processes to quickly diagnose COVID-19, and this goes over a little bit of our methodology, so if there's any questions on that, I'd be happy to expand further. Very high sensitivity and specificity for our COVID-19. We've now processed over 500,000 COVID-19 samples. And really industry standard, I'm sure as you all have seen in the news, turnaround time has been a major problem with laboratories across the United States. We've been able to stay consistently within 24 to 48 hours from the time of receipt. And our average turnaround times are about 12 to 16 hours from the time that we receive the specimen. So we're really industry leaders at this point as far as our turnaround time for COVID-19 is concerned. We're also offering antibody testing. This essentially, if you're not familiar with the antibody test, it is a test to essentially determine who has been previously infected with COVID-19, so that's an additional test offering. Again, high sensitivity and specificity and very rapid turnaround time. We also offer upper respiratory pathogens, so for example, flu testing. We offer a wide array of viral, bacterial, and fungal panels in our upper respiratory in the different offerings that we have for upper respiratory. This really allows for differential diagnosis. So if a patient does have COVID-19 symptoms, they test negative for COVID-19, we are able to ascertain whether they might be positive for a different viral, bacterial, or fungal target. We also offer sexually transmitted infections via urine or swab, again with rapid turnaround time. The CDC does estimate that there are 20 million new cases annually to a cost of $16 billion in direct medical costs for sexually transmitted infections, many of the pathogens that we test for, a patient can be asymptomatic. So really, again, we encourage patients to take their health into their own hands, ask their physicians for these types of tests, and I believe during the pandemic, sexually transmitted infection rates have actually increased, believe it or not. I guess people like spending time with their spouses at home. This goes over our testing menu for sexually transmitted infections. We also offer toxicology testing via urine or oral specimens. This goes over our testing menu. Again, I'd be happy to answer any additional questions, specifically in regards to toxicology. And then pharmacogenomics. As was mentioned before, this was the big test that we partnered with Sherrill Morgan and Sherrill Morgan's partners on. Pharmacogenomics, it's an aid to assist in the prescription of safe and effective medications at doses that are tailored to a patient's genetic blueprint. So really finding the right drug at the right dose for every single individual. What works for me might not work for an individual at table 1 or table 2 or table 3, which ultimately can help reduce healthcare costs and also patient satisfaction. These are the genes that we offer with our pharmacogenomics test. And then Get My DNA is another company under the umbrella of Gravity Diagnostics. This is an at-home testing kit. We are in the process of validating, obtaining EUA and FDA approval for the home collection kit for COVID-19. This is telemedicine enabled, physician approved, fast shipping, simple process, and accurate results. So in this particular scenario, a kit can be sent directly to a patient's home. They can complete telemedicine and have the results delivered to also their primary care physician. And that's all I've got. Do I have any questions on the test offerings? Okay, great. I'll give it over to Brian with MedBen.
Thank you. Good afternoon. I'm Brian Fargus, Vice President of Sales and Marketing with MedBen, and I'm going to focus more on the pharmacogenomics part of it, not some of the other ones that I would not want to talk about today. I'm going to focus on two pieces, how it can relate to your members and a health plan. And I'm going to focus on two, which are statin drugs and stress, anxiety, mood disorders, things like that. So I'm going to start with the statin drugs. Over 28% of the people in the United States take some type of statin drug. But what a lot of people don't understand are about 20% of those people, that statin drug doesn't really work for them or will have some metabolism issues with that drug. And when you see that, there's another drug that's been out in the marketplace. They're called PCSK9 drugs. I have to look at it every time because I can't remember those. And it's about a $15,000 a year drug, and it's a replacement for statin drugs when they're not working for that member. Make sure I get the right one here. I did the wrong one. Okay. The big green one. Okay. So let's take an example. Here's Phil. He's a 60-year-old male, has heart issues, suffers from high cholesterol, rheumatoid arthritis, and depression. And the doctor wanted to put Phil on the PCSK9 drug because of his uncontrolled high cholesterol, and keep everything else the same. And you can see all the drugs that Phil is taking for all of those issues, but that drug they wanted to change to was $12,662. And so that yearly, the average cost for that for Phil would be $74,287. What could have been done is Phil get a genetic test done. And based on Phil's results, there were a lot of issues, not just with the Lipitor that Phil was taking, but with Lipitor, it was obvious that Lipitor is not a drug that would work based on his genetic profile. And so moved Phil to Crestor. By moving Phil to Crestor, which was shown that will work for Phil, eliminated the need to take that other drug that cost $12,000 plus. Along with some other things where it was a poor metabolizer for Plavix that found out. And for those of you who don't know about Plavix, it's a blood thinner that can be deadly for some people if it doesn't work for you. And so they found that out and changed Phil from Plavix to a combination of different drugs, including aspirin. And then there's also a poor metabolizer for Geljans. And what they needed to do there was just change the dosage for that. And you can see, based on the cost of the drugs on the left-hand side where he was taking, and then to the right-hand side, it was a 48% decrease in pharmacy costs. But the better thing is, there could have been additional problems from a healthcare side because of the Plavix issue and other things there. So it's not just a savings, but we got Phil on the right drug, and hopefully going down the road that Phil would have a better health because he was taking the right drugs. Another one I want to focus on is really the depression and anxiety and mood disorders. There have been a lot of studies from 2013 to now on those type of drugs. And this study here in 2013 found that the people that were taking suboptimal prescriptions that really weren't working for them had 2 times the amount of healthcare visits, 3 times the amount of absentee days at work. So basically the result is higher costs for that group and less productivity for those employers. A 2018 study showed the same type of results, looking at the group that did take the test, had the right drugs, and they had 40% less ER visits and 58% less hospital visits. That's a big thing. That one saves the plan money and basically keeps the person healthier. Why did I pick on the anxiety, mood disorders, and stress is because this is from March of 2020 through August, the telehealth visits that our block of business experienced. And if you can't read that very well, you can see there's a pretty big difference from the top 3 to everything else on the diagnosis side. The main diagnosis from telehealth visits were mood and anxiety disorders. Number 2 is depression, and number 3 was mental health conditions, other. And so you can see it's really dominating from a diagnosis standpoint, and that's just that's during our COVID period. And so this would be a good time to take a look at and doing genetic testing to make sure that people are on the right medicine, because everyone knows someone that's just suffering from whether it's mood, anxiety disorders and things like that. And you hear all the time, whether it's a family member or a coworker, that I had to go to the doctor because they had to switch my drug, switch my medication. The reason why they switched it probably because their body didn't metabolize it correctly, and so they finally got them on the right one. From a personal experience on the statin drugs, years ago I had high cholesterol, and doctor put me on a certain drug, and all of a sudden I was getting really bad muscle cramps in my legs and feet. And when I went back and talked to him about that, he said, well, try this one, and he put me on Crestor, because it says it goes through a different absorbed through a different pathway in your body, and sometimes this works when it doesn't work for this type of drug, and put me on Crestor, and it worked perfectly. A couple years later, when we got into this, I got a genetic test done, and it showed the drug that physician had me on at first doesn't work for me. It shows that Crestor did work for me. So there's a lot of things that not just if you're going for, just like Phil, that it was because the statin drug wasn't working. There were more things that could have hurt Phil long term, just by he found out by getting that test done. So these are ways that can affect your members and your health plan. One, the main goal is to get the people on the right drugs and make sure they're healthy. And the benefit of that is they're healthy and it saves the plan money long-term. And so that's what I had. That was my job to talk about how it affect the members in the plan. Any questions?
I'm just going to say it, you can repeat. So to make the best use of that, you need a link between the test and the primary care physician, right? Who's going to change that prescription?
Yes.
All right, so can you speak to that a little bit? How are you linking up to the physician groups who need that information, and how are they, is it electronic linkage?
So one thing that we've had groups do where the member will get a report on how their test results were based on certain drugs, and that can also be mailed to that person's primary care physician, and that person can also speak with their primary physician. I took my report right to my primary care physician and had a discussion about it. And but Mark, I'm not sure if there's anything else you want to add to that.
When we've set them up through physicians' offices or clinics, then the physician is the order and getting it right then and right there. So that's one methodology that we've used to get it. It's actually the physician originating the discussion with the patient in those circumstances. In other circumstances where we have a PBM involved, they have an electronic format that some of the PBMs can communicate with EMRs and communicate that business into the EMRs. Not all, but some. So there are two methods. It is not a perfect situation I'm aware of yet, but I think there's some other people with comments or knowledge on it than I have.
Okay. Thank you. Thanks for the overview of your PGX testing. My name is Ron Sengupta, a company called RxPredict. We've been doing work with Gravity, and they're an excellent lab. And it's delightful to see Jennifer here. So two questions for you, Jennifer or Mark. The FDA in April of 2019, I don't know whether it was pressure from the drug companies or it was validation of tests, issued a warning letter to Innova in Washington, D.C., saying there are only certain drugs that you can do pharmacogenomics testing for. And they withdrew the genetic testing. Big companies like Mayo Clinic just now do 33 drugs. In addition to statins that you showed and mental health, statins you can measure with a blood test. You can see if the cholesterol went up or down. Hypertension, you can see if blood pressure went up or down. With mental health, it's hard to measure depression. Say, how are you feeling today? Or you feel better? There's no meter that says. And so the trial and error rate is ongoing, and drug costs, as Mark mentioned, you may have to go back to the doc 4 or 5 times for mental health versus statins. What has been your experience with the FDA's position to open it up for oncology, is the FDA loosening its grip? Is it going to allow more than 33 drugs? Or is it still going to shorten that list till the drug companies say that these tests are valid?
Okay. So I think there have been a lot of pharmacogenomics, genetics companies that have been very popular over the years. And I would say that the FDA, I think that when they came out with that, that was, an effort to try to control the market a little bit. So I will say, everything that we do at Gravity Diagnostics is within FDA compliance. We have EUA certifications, our at-home testing kit. But I do think that they're loosening their grip a little bit because I think that they see that, the overall benefit of how, especially for anxiety and depression, for mental health, if, there is a test that can more accurately predict the medication, the dose that an individual should be on, then I think as a country we're better. So to me, yes, I do believe that they're loosening the restrictions.
I have a quick follow-up to that. So just that you all work with Kroger Health, and Kroger has announced Food is Medicine, their initiative. And as Mark was mentioning, eat healthy, be social. So we pivoted from medication to diet and exercise, which is a lot less controversial. Are you seeing that kind of demand in the market where people are saying, how many carbs should I eat? If you can do it for statins, how about carbs? How about proteins? How about all these diets? Are you seeing any wellness, personalized wellness?
From a health plan standpoint, I know that many of our employers are implementing different health and wellness programs, giving points for and actually helping pay for gym memberships, things like that, and having certain activities where if employees can show that they complete certain things, go to the gym certain amount a week, or go to Jenny Craig, or do certain things like that they can get credits for, vacation days off, things like that. So there's a wide array of things that employers are doing, but I wouldn't say there's one standard method. We have a comment back.
I was just going to say that in addition to that, there's been a huge push in the laboratory world for nutrigenomics. So this would be an additional genetic test that would essentially show a person's response to certain foods. And so that is coming down the pipe. There's been a lot of research on that. Hopefully something that Gravity Diagnostics will also offer in the future.
Thank you all.
Mark, I think Brandon had a comment back there.
Last question, just real quick. So I missed part of it. I saw there was a lot of bodies up in rows, orange and blue. Have you guys had enough empirical data with your block of business to give like an average of how many people on a particular, let's say 100 lives, how many people are impacted positively or could be positively impacted by this program? Is there a statistic like that we could go to one of our, for example, governments and say, we're finding out that 1 in 100 people or 1 in 25 people are really have a potential to be positively impacted? I missed that. If you guys said that, I missed that part of it. Probably my fault too.
Within our block of business, no, we don't have enough data to give an empirical answer to that of what the results are for testing. There is data published by other entities that talk about things like, statins, whether or not they're able to take them, but to comment earlier, you don't always have to have a genetic test to determine efficacy.
Okay. Thank you.
All right, great, thank you. All right, well, thank you, Gravity and MedBen, for that presentation. The technical ones and the ones that are pushing the envelope always get the tougher questions. So we appreciate that. Is this on now? Okay. So throughout the years, known a gentleman that really come to appreciate, and he was my doctor. Then he left me, and because treating me is just that hard. But he worked with an organization with us that was on our clinic staff for the clinic that we had in Covington, Kentucky. And he went on to there, and then he decided to try to fix things in northern Kentucky and do some great things there. And he went on to back to his the old-fashioned way of life of just being a good old-fashioned practitioner and doing other things, though, still expands his horizons all the time. Maybe if I'm lucky someday again, he'll be my doctor again. And that's all. But he's someone loved by our organization and by the people that know him. He was at our very first conference speaking. That was 7 years ago now, right? Very first one speaking. He spoke in, we've only had him take a vacation 1 or 2 years to not speak. But every single time he speaks, he's the only speaker that comes up here and outrates me on the surveys. He outrates everybody. He's probably one of our most loved speakers because he knows how to speak from the heart and not only just from the intellect. So on that, I would like to introduce Dr. Gerry Tolbert to you and welcome you back, Gerry. Thank you.
Up to that. So I'm going to leave this on. I see patients on a regular basis. I see them in the clinic, and there is a chance that I could have been in contact with somebody in the last 10 days that had COVID. It's always possible. So I don't want to get my drops on you. If you can't hear me, just wave, but I'm usually pretty loud, so I expect that it should be okay. So Mark asked me a couple of months ago to speak about preparing for the future. Obviously, I left off something that's in the program. If you look at your title, it says COVID-19, preparing for the future, right? It's pretty obvious that we're in the middle of COVID-19 right now. it colors everything that we do. It is not something that you can actually do anything without thinking about it right now. And if you are doing that, you may want to rethink what you're doing, because it is a very important thing, and it is still a very important thing, and it will probably continue to be a very important thing, probably for the next 6 to 8 months at the very least. Very smart people, when all of this started, that I trust a whole lot, gave a projection of about 18 months for a true, complete response, answer, whatever you want to call it, before things start to get back to a baseline that we're not going to call normal, but we will call homeostasis, and we'll come back to that. I hit the big green button, nothing happened. No, I'm kidding. Normally I control my own slides, so this is one of those where other people's tech, I get a little nervous. Yes, that's a joke. Yes, it's a pun. I know that's not how you spell paradigm. The point of this slide, however, is more for me than for you. Most of my slides, if you look at them, they're pretty sparse, and there's a reason. What I say is way more important than what's on the screen. If all you're doing is reading, or if I'm just reading it to you, I'm insulting you, and I don't want to do that. And you're not paying attention to what I'm actually saying. And what I'm saying here is we've got a lot of stuff. As Mark pointed out, I told him he stole my thunder a bit. We have so many things in our culture, and especially in medicine, that have been unmasked by COVID as things that we did because we could get away with it, not because they were things that we should be doing. Access. The reason that's on there, we have so many patients that have so many problems getting to see a physician, getting to see their physician, which is incredibly important. That relationship between a patient and their physician is considered sacred in a lot of places. We talk about that in medical school. This idea of the circuit riding doctor, I stole that, the circuit riding preacher reference there, and I promise, I put these slides together a while ago. That idea of the doctor that made house calls and went place to place and went to the patients. The reason that changed was not because the doctor got tired of driving around. It was because you could put one doctor in one place and 100 people could come to him. But if you sent him to 100 places, it would take him 2 months to get there. That's why hospitals exist. Shh, don't tell the hospitals that. Because they don't seem to understand that either. And I say that as an employee of a hospital. I have several different hats, as Mark said. I have several different jobs. I'm the medical director for the Northern Kentucky Health Departments. I am a family physician in Union now. I was in Burlington, but we opened a new office, and I've moved over to that side of the highway. I have done house calls throughout the course of my career, and I would still do them every day if I could, because it's about going to meet that person where they are. And what happened during COVID is we started doing those house calls, but we started doing them virtually. Telehealth and the idea of the home office became a much more prominent thing in medicine. And what it showed us was we can actually do that again. We can actually be on a one-to-one basis, and we don't have to be in one place. We don't have to be in a specific location. We can take care of people wherever we go. That skill set is translatable. It's not something that only works in one place. The digital clinic is this idea of the future. And so when we talk about what's coming, what is this idea of how you receive your medical care? Is it, I'm going to go see one doctor, and then they're going to send me to this doctor, and then they're going to send me to this doctor, and then they're going to send me to this doctor? Well, before COVID, yeah, that was how it worked. And we were slowly seeing these inklings of, well, we could maybe do a virtual video conference with that other doctor, and we could have everybody in the room and do it. But that's really hard to do, and the technology's just not there yet, and internet speeds aren't fast enough. We've blown that lie, is the best way to put it, out of the water. There was this comfort level of, well, they don't want to do it, so we're not going to do it. And what we found is, if you got to do it, you realize how easy it actually is. So there are lots of places now, lots of large institutions that are looking at those virtual visits as a group effort. Instead of a primary care physician seeing the patient and then moving to send them to a specialist and then having to interpret those notes and figure out what happened and make sure that the medication list has been updated correctly because of what somebody else did. Now, the three of you can have a conversation, whether it's in the same room or virtually, with none of you in the same state. And that process of discussion not only helps make the primary care physicians better at what they do, it also makes sure that that patient is as safe as they can possibly be. Because now, everybody's talking in the same room, and if you have a question, if you have a concern, it's not weeks from now or months from now that gets answered or figured out even. Immediately, at the point of care, you are figuring out that there is something different or something new that needs to be done. So we've got an opportunity now in medicine to be able to do that kind of thing much more frequently with higher level acuity and be able to give the patients a optimum experience. I'm trying to use all these buzzwords to make sure I fit in, right? The idea there is if we can help people stay healthy, be healthy, and get healthy, that's literally my job. That's why I go to work every day, right? So if that takes a new tool set, the stethoscope has been the same, give or take, for the last 300 years. People were using metal horns to listen to hearts. The tube got a little longer so that somebody's not putting their head against your chest. That's the main difference. And so because of that, we have a tool that we have used for a long time that is still the center of a lot of different physician practices. The same thing's going to happen with these digital tools. They are a versatile set of tools. Really, it's one tool, but we're using it a lot of different ways. And so that's a big thing. For those of you that may have been under a rock, no offense if you live under a rock, equity right now is a massive issue. How do we make sure that everybody gets the things that they not only need, but also the things that are going to keep them healthy? And that has a lot to do with all of the different factors that we bring into play when we see a patient in the office. Balance. Physicians are really bad at balance, most of them. We have a problem saying no when we're the good physicians. And that doesn't mean that it's bad physicians that say no all the time. It means we tend to work until we fall apart. And there's a term that gets thrown around a lot, burnout, and we hear it in all kinds of different venues, but medicine right now, for the last few years, it has been a massive buzzword. And the truth of the matter is physicians cannot sustain that kind of lifestyle and still help the other people around them. Most of it is kind of confused, and we have to be careful. I don't want to step on toes when I say this, but we as physicians sometimes misunderstand because we're so used to being analytic and we're so used to looking for root causes that we kind of miss this idea that maybe it has to do with the structure that we're in, not with the processes that we do. And this idea of homeostasis that I brought up before, this idea that everything moves to the middle. Our bodies operate on that principle. And in fact, the genetic testing, see, I'm bridging all the gaps today. The genetic testing that they just talked about is a lot about homeostasis. We can tell you if you have a gene, a copy of a gene that is going to do certain things in your liver to metabolize certain chemicals. And it doesn't matter what those chemicals are. Sometimes it's water, sometimes it's something from your food, sometimes it's a medication. But what we're telling you is that you have the potential for that thing to happen. And it may happen a little bit, it may happen a lot, it may happen an average amount, or it may not happen at all. That's 4 possibilities. And we're talking about upwards of, 23 chromosomes, several thousand genes that all interact with each other. So now you start to see why some of these tests may actually be limited in their application. The problem is not that we can't test for it, it's that we don't know what to do with it once we've actually seen the answer. Because we know what that chemical is going to do. We know that you have the ability to process it. What we don't know is what you're going to do for the rest of the day after you take that medicine that may also have an impact on you processing it or using it the right way or responding to it. And that's where that relationship thing that Mark was talking about comes in. Decade after decade, there are television shows about physicians. Some of you have probably seen some of them. One that has stuck with me since I was probably about 8, 9 years old. There was an episode of Doogie Howser. Great show, right? Neil Patrick Harris. Great guy. There was an episode of Doogie Howser where the key to the patient getting sick and then getting better was that they were eating off of pre-kiln fired, so non-fired pottery dishes that they had been handed down through their family for years. Somebody asked that question in the exam room. What kind of dishes do you have at home? Has your doctor ever asked you that question? And if they have, let me know, because I want to meet that guy or lady. This is one of those things where that level of knowledge of a person's family or their habits, we don't do that. We stay on the surface. And because of that, we miss the important pieces. We miss the things that actually answer the question. And so this idea of these set points, we've gotten in this habit of staying shallow, of just breaching the surface, just to get enough for what we need. And if we don't ask the right question, then we don't get the right answer. And Mark tells the story every time he pulls up to talk about this, and I'm kind of sad he didn't today because he didn't tee me up for it. But that's how Mark and I actually got our start. That's how Mark and I became friends. I'm going to say that word because I think we're friends. We don't talk as often as we should, but COVID changed that for everybody. Mark has an issue that I'm going to let him talk about, not me. But through the course of discussion, we figured out how to help that issue way more than any medicine or anything we could have done could have helped that issue. But it was because we talked. We sat and had a conversation. That's what medicine's about. Most people don't realize that. We talk about the history of present illness and the review of systems, and we have to meet these markers if we're going to get paid by insurance to do these things, at least until next year, which is an awesome thing coming. We'll talk about that in a minute. And so we have this idea that we have to do it a certain way because that's how it's been done. And the truth of the matter is it's only been done that way because people get too busy, or they're seeing too many people, or they're not giving enough time to it, or somebody somewhere decided that was a great way to do it without any evidence to say why, but then they taught 100 other people to do it. And because it was more efficient, it got done over and over and over again. And we see that happening in medicine all the time. We can track it back to the person who came up with that idea to begin with. And sometimes it makes sense, and sometimes it's a really bad idea. So coming to that balance, figuring out those set points, figuring out where the new set point needs to be, that's the future of medicine when it comes to equity. We've got to figure out how deep we've got to start going to really get to the root of some of these problems and stop missing the important parts of our patients' lives because we aren't going deeply enough. Culture, very tightly tied to equity right now, and that is something that we have to be utterly not only aware of, but we have to be ready to address all of the different things that are going on right now in our culture and how they drive what's happening. And COVID has unmasked a lot of the things in our culture, some of the stuff Mark talked about with gathering together and families and other things. Education. How many of you all have or have seen somebody that has kids that are dealing with this education system right now? I have 2 6-year-olds and an 8-year-old. They have been home for the last 10 months. 10 months, yeah, it's 10 months. So I put up 9 fingers because it's technically 9.5, but I'm rounding up. Because anyone who's done it knows that it feels like forever, right? But there are ways that it has been an amazing thing. A prime example, when we talk about changes and when we talk about innovation and we talk about the future, one of the things that's come out of this, there was an interesting study this past week even, that there are certain students that are doing amazingly with NDI. Anybody care to hazard a guess who they are? Anybody? And this is, I'm really asking. Introverts. They're doing well, but they're not the ones that the study was about. I can tell you from experience that yes, introverts are doing very, very well. I don't have to go anywhere. No, so kids with ADD. Kids who are not used to sitting still in a traditional classroom for 8 hours a day, doing exactly what somebody tells them, exactly when somebody tells them, they thrive in a situation where they can do their work whenever they want. They learn more. They're getting more done. They're being better students. Who knew? The guy with ADD. I can tell you, if I didn't have to go to class ever, I never would have. I love learning. I enjoy being taught. And I know that's a skill sometimes. Being taught can be a skill just as much as teaching. I love it, but I hate sitting still. They've tied me to a podium this year. If you've seen me in past years, I wander, I roam, I move, I pace. It's because that's how my brain functions. And so if I can distract the rest of my brain by making myself do those things, the part that is in charge of saying things gets better at doing it. It doesn't have to work as hard. Entertainment. We are sitting in the shadow of massive fields that are usually filled with massive numbers of people watching a game in person, but have not been, and probably will not be, for a very long time. There are tons of, to jump, because I don't want to just pick on the sports people, there are tons of productions in television and movies that have been pushed back. The theaters are not open. If they are, they're not showing movies that you want to see. They're showing movies from 20 years ago. We are not able to do the things that we would do with our disposable income. And it's starting to kind of show in a lot of other arenas, including healthcare, that people actually have money to start doing things that they didn't have before. Does that mean that entertainment is bad? No. Does it mean that they aren't finding other ways of entertaining themselves? Yes. But what it means is there may be a prioritization there that needs to occur, especially post-COVID, around what we really lift up and where we put our money. Because a lot of what we're doing these days, pre-COVID, we can't do now, and we're seeing these shifts. And it's not a zero, I mean, it literally is, I should say, a zero-sum game. Zero-sum game. When one person wins, the other person loses. That's what a zero-sum game is. So if you take money out of that pot, it's got to go somewhere. And so most of it's staying in the pockets of the people that would have otherwise been spending it. And that means that they can eat, and they can have shelter, and they can have housing. But if they already had those things, and they were already secure in those things, now they've got money to spend on other stuff. And what we're starting to see is that that's coming into play in a lot of other ways. We're seeing a lot of random things. Boutique healthcare. Who knew? Well, I'm going to take care of my health. If I have to be stuck and I've got extra income, I'm gonna actually go get my face lasered. Not that there's anything wrong with having your face lasered, but just know that it's probably not going to do a whole lot, just FYI. Poverty, food security. These are things that we don't always think about, but we absolutely need to. Because right now, that divide I was talking about, that extra income, it's getting wider. And we're just starting to see that. Over the last couple of months, we've started to see those folks that didn't already have a lot, they really don't have anything now. So how do we, as folks who are able to drive here in our cars and sit here and listen to a talk from a guy who, who knows why he's even talking, we can do that. We have the disposable income to be able to do that, or we have a job that lets us do that or makes us do that in some cases. There are lots of people that don't have that luxury, that don't have that ability, and what do we as the folks on the other side of that, what's our responsibility to those folks? What's our ability to help them figure out the best way to keep themselves alive? What's the minimum that we can be doing to help them? And from a medicine perspective, we have to stay on top of that, because those folks are the ones in the medical system that get disenfranchised, that don't get healthcare at the right time, that don't get healthcare in a way that they need to. They may not see a doctor for years because it just doesn't have the priority that putting food on the table does. They work 2 jobs, they have kids that they have to do NTI for even while working those 2 jobs. And if they get sick, everything falls apart. They lose their house, they lose their ability to take care of their kids. So how do we make sure that that doesn't happen in the healthcare system? How do we set things up so that we're not beholden to rules that are archaic about how we charge for things? Right now, Medicare says if I take care of somebody for a certain problem and I don't give them a discount and charge them a full amount, then I charge the same person that has Medicare the full amount as well. If I discount something for that other person that has nothing but doesn't have Medicare, I have to discount it for Medicare as well. So the rule is you give me the minimum number that you're going to give everybody else, because once you've discounted it, you've now said that this is what that service is worth. It's an archaic rule, and it needs to change, because we need to be able to help those folks that need the help and not be beholden to these numbers that are for folks that may actually have resources. So there's a lot of stuff going on. And I'm turning the curve here, and I promise there's not a ton more to talk about, even though there are more slides. So what prevents certain populations from achieving the same level of health as other populations? And again, like I said, Mark stole my thunder. There's a lot of stuff out there, right? There's a lot of research. There's a lot of places that you can go to read about this stuff. Is it nutrition? Yeah, kinda. Is it healthcare? Yeah, kinda. Is it sanitation? Yeah, absolutely. If you have flush toilets and running water, you're gonna live a lot longer than people who don't. That's the public health official in me, kind of quoting the science. Is it vaccinations? Yeah, kind of. We're learning more about that as we go along over the last couple of decades. We used to think that there was a much larger proportion of health that came from things like penicillin and vaccines. There's a lot there, don't get me wrong. They're very important things, and I want everybody to make sure that they're still doing things appropriately when it comes to treating infectious disease. But just having clear running water, just having access to the right kinds of foods, a lot of that stuff was more than enough to bring people up to near the same level of life expectancy as us. If we can drop down childhood mortality, we raise the life expectancy way more than if we try to take care of people at the end of their lives and extend that by 5 or 6 years. So it's more about things that are going to influence babies surviving, pregnant moms getting the care that they need, than it is about trying to make sure that a 75-year-old with stage 4 cancer lives for 6 more months. Is that still important? Yeah. But do we need to be spending $2.5 million on that person while we spend $20,000 on that pregnant mom? And how do we rate that? How do we decide that? Who gets to make that decision? Who's the ethicist that has to make that decision in a system that has limited resources? There's no easy answer, and there's no one answer for any of this stuff. But the future of medicine is trying to figure that out. Because if we don't, we're going to stay right where we are. We're never going to get better. We're never going to improve. And we run the risk of getting worse. So where do we go from here? Anybody recognize that symbol? Say it louder, sorry. Close. So technically, it's a Sagittarius. For those of you that believe in horoscopes, this is to say that I do not, but that doesn't mean that you can't. They should understand that that's what that is, but it's really a centaur. And the reason that picture is there is because the future of medicine, the thing that we're going to be seeing in the next decade that is going to be the most important, is how do we take the tools that we've got and use them to do all of those other things? How do we not lose the high touch, but learn the high tech, right? And I call it the new AI. This is not, I'm sure somebody else has said this somewhere, but it kind of came to me when I was writing this down. I was like, oh, that sounds genius, so I'm going to write it down. I call it augmented intelligence. We talk about artificial intelligence all the time, right? You got the computer that knows how to do things. Most artificial intelligence is very good at one thing. It can play Go and beat people at Go, but ask it to tie a pair of shoes and it has no clue where to start. Or it's really good at telling you how to get from point A to point B from the shortest distance with the fewest stoplights and the fewest speed cameras. But is it really intelligent? And what does intelligence mean? And that's a whole other philosophy course that I'm not even going to dive into. This idea of virtual versus augmented. Virtual reality versus augmented reality. For those of you that are more tech-oriented, virtual reality is going into a place where you can't see the outside world. Augmented reality is overlaying other things on top of the real world. And this augmented intelligence idea is saying, all right, there are some really good computers that are really good at certain things that can help physicians make decisions. In fact, right now, radiologists are shaking in their shoes because we've got computers that can diagnose certain conditions way better than any radiologist ever could, because they know how to look for subtle signs that are microscopic in these films that a radiologist couldn't see even with the best pair of glasses in the world. But when you put the two together, they're like ninjas. They find it all. And that's the concept of the centaur. That's the idea where a human and an artificial intelligence are working together to create something that is way better than either of those two parts alone. And so machine learning, artificial intelligence, those are all things that you're going to hear, buzzwords that you're going to hear that are really important. But without the human connection, especially right now, they're not going to mean a whole lot. They're these baby steps and increments that we do that are going to sound really cool. But when you put them into practice, they don't really mean a whole lot, until you start pairing them up with somebody who understands what they actually mean or what they're actually saying, or can ask them questions and make them better. And then we start seeing things take off. The whole concept of augmented intelligence and this idea of these centaurs in medicine is just in its beginnings, but it is becoming incredibly popular. I talked earlier about having a conference with multiple physicians. What happens when you don't have access to those multiple physicians? So let's say that there's a specialty that doesn't exist in this region, and I need to talk to that physician, but so do 500 other people. Well, I got to get in the line, right? What if we could take what that person already knows, and through years and years of watching that person act, reading their charts, reading their descriptions, listening to them talk, we could build an artificial version of that person that anybody can access at any point with no limitations. People are doing that right now. The collected knowledge of people that are really, really good in their fields is being converted into an artificial version of that knowledge. Because it's not just about the knowledge, it's about the context, right? I can tell you that this is a phalange and this is a phalanx, and that as you move this, you're basically activating 3 different major muscle groups that are pulling on a tendon, that it's interacting with a specific piece of ligamentous tissue, and you're going to get bored and you're not going to care, right? But what you really want to know is, why does my finger hurt when I do this, right? If somebody tells me what's going on and I didn't already know, I've got the context. I've got the room in my head where that belongs. If I didn't know that specific fact, now I add it to the stack, and I can actually explain that to you. So from a primary care perspective, that's my job. I sit around all day long translating science and doctor speak and whatever else you want to call it into, hey, why does this hurt when I do it? Or what am I supposed to do about this? Or what does that lab actually mean, right? That's my job. And taking those large volumes of data, back when I was just getting started about 20 years ago, we could fit everything that we knew about drugs in a book that was about that big that we carried around in our pocket. And now, I have to carry around 5 devices and have logins for multiple different systems to be able to look at that stuff. You know, to actually truly, honestly look at genomics data in a good way, you need a computer. You can't do it without one. So what's our job? What's our ability to take these folks that are well trained, that are highly trained, and then multiply them? You know, we have the ability to do that now, and that is going to be the future of medicine. That multiplication in time and space, that ability to be wherever the patient is. Does that mean that people are going to be gone? No. But it means that we've got to start looking toward this idea that a lot of our healthcare is going to be coming from people that may not have originally been trained in that one area. You know, it doesn't mean that you've got to go see that specialist anymore. It means that the person that you're seeing needs to know that specialist, or at least know what they know. So this idea of specialist priority, right now, in our current healthcare system, and pre-COVID especially, people got referred for everything. If you've ever been to a doctor, you've probably been referred. These days, that's harder to do, but when people get referred for everything, the specialist gets burdened with things that they shouldn't have to deal with, and then when the cases come along that we really need them for, we can't use them. So we've got to be very aware of all of that. We've got to figure out what essential means in medicine. Who are the essential workers? Who are the people that have to be there, that have to be a person? And who are the people that can then multiply themselves by not being a person, but by being a set of skills and a set of facts and a set of knowledge, a fund of knowledge? And then how do we get that communication out to the people around us? That's the future. That's where we're headed. I don't have any answers for that. I wish I did. But I can tell you that that is where we are headed if we pay attention to what's actually going on. And that's going to impact a lot of what you guys are doing in terms of the healthcare that you give to the people that you're involved with, your employees, or to the folks that you're in charge of. So we've got to make sure that we are providing you with those kinds of resources so that you have a workforce that can actually be functional. All right, I told you I was almost finished. Any questions before I quietly walk away? All right.
Thank you, Dr. Tolbert. Dr. Gerry Tolbert, like I said, he can bring the humanity to a situation pretty well with the way he talks about it. So I really appreciate his participation with us throughout the years, and we look forward to his participation with us in the future and all. That's one of the central aspects of healthcare. We always come away thinking it must be how our plan covers us, it must be our technology, but really it's where does our technology and our health plans and our humanity all come together in one place at one time, and understanding that our humanity, our social structures are just as important as our technology structures and our payment systems. You know, if we get away from that, then we lose what we took millions of years to develop in our own circumstances, our own bodies, is the ability to be close and tight with one another. And it's how come we have an immune system to begin with, because we make each other sick all the time. It has been one of the most unusual years of our lives. And I was talking with Dr. Tolbert earlier. It's like we're like all on a moonshot. We've never been here before. And there's very few people alive that were here before in 1919 because they were infants. So we have no point of reference. We have no say, what happens next? Why are we still doing this? Isn't this the flu? Why is it more than that? And I think sometimes we get lost in the very short vision of where we are today. And all we can see is the moment that we're in. And I think we just need to find a way to realize that, as said before, this too shall pass. And that we'll need to find a way to bring back together and come back together better than we did before. Because I think what Dr. Tolbert brought forth very clearly is that some of our systems were broken. And some of our systems needed to be broken. And not necessarily put back in place just because COVID ends. But realize we need to build new systems, new ways of doing things that take care of us as individuals and as a community. And having said that, this almost brings to an end is it our seventh annual conference here. We used to have them across the country. Not across the country, across the region. I should say, yeah, across the country. Yeah, you should have been the one in Los Angeles in '90. It was awesome. Across the region. But so now we just have our annual conference where our customers come together and our partners come together. And I want to thank all those that took the time to join us online, to be a part of this with us today and have to sit there and endure all this through a computer screen. I want to thank all of you that took the time to be here today and be socially distanced and yet still be able to participate in an in-person conference. I want to thank our staff for doing something very unique and very different and it's doing it very, very well. Now, you don't have to go home, but you are going to have to leave this room because there is on the rooftop a reception that is beginning, and probably by the time we all filter out of here, get our stuff together and head to the roof, they'll be ready for us. And don't worry, it's a covered roof as well as an open roof, but it's all open air and all. So thank you all for joining us this year. We look forward to seeing you next year in a completely whole new world. Hopefully, yes, thank you. Good, thank you.